Guess we're good to start. Can everyone hear me? Great. Well, good evening and welcome to our pre-election town hall on major health concerns for New Brunswickers. My name is Carolyn Watson and I'll be your facilitator this evening. Now, before we start though, I'll just ask Rose to stand up and wave to the group. Rose is your primary event organizer here, and she's been working really hard, so thank you very much for putting this all together. Plus the team, of course, there's been a lot of people, but for those of you who have had to correspond with Rose before the event, you can now put the face with the name. I also had the chance to speak with Rose a little while ago when she contacted me to facilitate this evening's session. And I could tell the passion that she and their team had about tonight's session. And she listed a number of things, and there's a couple things that sort of stood out for me. And one being that it was it was brought to you by two partner organizations, the Canadian Arthritis and Patient Alliance, as well as Save Your Skin Foundation. What also stood out was the fact that we would be hearing from representatives from various political parties. So my first thought was, oh, okay, this is a workshop hosted by various political parties on how to save your skin. No, alas, I was wrong. So please don't make the same mistake that I did. This is a non-partisan event, and these folks have graciously accepted to come and speak as well as answer some of your questions. So I also believe that everyone here is here for a good cause, for a good reason. In fact, I'm sure we all have our own stories, whether it's you're directly impacted or a loved one has been impacted by any scary health concerns. It's just not a good feeling, and you want that reassurance. And I can relate because 2 years ago, my then 4-year-old, Geneviève, suddenly had eye issues. And just out of nowhere, her eyes were going cross. And we didn't know what was going on. It was really a complete mystery to us. And after, at this point, she'd lost her 3D vision, which I didn't exactly know what that meant at the time, but it was scary anyway. And her overall sight could have been impacted as well. So after an MRI and several medical professionals, she was operated on in Miramichi. That was the only place that they could find an operating room and line up the doctors and everything. She woke up, her eyes were straight, lo and behold, and her 3D vision has gradually come back and all is good. Now this happened over a year, and it was not fun. It was very scary at times, but I do realize that Genevieve's story has a happy ending. And tonight we're taking the opportunity to be able to share some of our experiences, to be able to improve, hopefully, the experience for everyone and have more happy endings for our health concerns. So, excuse me. What I would like to do also is take the opportunity to thank the following organizations for their sponsorship. So there is AbbVie, Amgen, AstraZeneca, Innovative Medicines Canada, Janssen, Merck, Novartis, Novo Nordisk, and Roche. Now on to a few housekeeping, where this town hall is very informal and being a true maritime way. I would like you to know where you can find some of the key things, like the washrooms are just outside in the hallway here, and you'll find them at the end of the hallway, your right and left. As I mentioned earlier, there's also some snacks there and beverages, coffee, tea, and water. And there's no planned breaks throughout tonight's session, so please do feel free to get up and find some refreshments. For those of you who may be smokers, it was highlighted to me that there's only one location where you can smoke. It's outside, across from the main entrance, a yellow pole, a big yellow pole. That's where you can go. Please do not go elsewhere if you have to smoke. The agenda for this evening can be seen on these rotating slides. And it just magically disappeared. There we go. Excuse me. And so I would like you to note that we've allotted a specific amount of time for after each group of speakers. So there's 4 groups of speakers coming on, basically. So there will be an opportunity at 4 times to ask questions to these individuals. The other thing I want to point out is this is primarily an English town hall, but if you have any questions in French, please feel free to do so. Je suis française aussi, and I will try to do a little bit of some translation back and forth at best of my abilities. I'll give a brief introduction to each of the speakers and be that timekeeper for you, making sure that we keep things really on track, because we don't want to stay here too late tonight. We do have until 9 o'clock, and we're told that we have to be out of the building by 9:30. So now tonight's event is also being live streamed to accommodate anyone who was unable to attend in person. So for those of you who are watching the live event on stream, we ask that you submit your questions for each section. Now you can send it to this email, so questions.monctonth@gmail.com. Again, that's questions.monctonth@gmail.com. Now it's important to note that please specify who the question is for the specific speaker, if there's a specific speaker that this question is intended to be for. So again, just a reminder, although we are hearing from representatives of various political parties tonight, it's not a political debate, okay? It's not a political debate. This is a nonpartisan event. We asked our speakers to focus on issues or problems or challenges in healthcare that are systemic in nature. We would ask the same of you, so even if you have a great or not so great story, personal story, we ask that you use it to ask your question that relates to a policy change that would fix or improve a systemic problem or challenge related to healthcare. Unfortunately, we won't be able to answer all the questions because I'm sure there's a lot of burning questions here. We'll have about 15 minutes roughly, depending on how long each speaker goes. We'll wrap up at 9, vacate the building by 9:30, and that was very clear. We need to be on time. So, without further ado, I'd like to introduce you André Picard. André tonight he's going to kick off the town hall. André is one of Canada's top health and public policy observers and commentators. He is the health columnist at the Globe and Mail, where he has been a staff writer for more than 30 years. He is also the author of numerous books and has received much acclaim for his writing and for his dedication to improving healthcare. In 2010, he was awarded a National Newspaper Award as Canada's top newspaper columnist. André has received much acclaim for his writing, including the Michener Award for meritorious public service journalism and the Centennial Prize of the Pan American Health Association, awarded to the top health journalist in the Americas. He is also an 8th-time finalist for the National Newspaper Awards. That's Canada's version of the Pulitzer Prize. Without further ado, please help me join me in welcoming André Picard.
Thank you for that very kind introduction. It's longer than my speech is going to be, so that's great. Alors, c'est toujours un plaisir de visiter l'Acadie, mais je vais parler en anglais ce soir. On m'a demandé de parler en anglais, mais je serai content, évidemment, de répondre aux questions en français après. So welcome again to the Town Hall. Thanks for coming out. We had some really tough competition from this weather, so I hope it's worthwhile you're coming in tonight to this lovely air-conditioned room. So the provincial election in this province is only about 2 months away, so it's as good a time as any to talk about the state of healthcare. Few things are as political as our healthcare system and the state of healthcare and healthcare funding. And even fewer things are more important. So this is a really important issue. It touches us, all of us every day, or our family members. Yet there are some people who believe, as Prime Minister Kim Campbell regrettably said way back when, that an election is not the time to discuss serious issues. She never got forgiven for making that little quip. But we're going to make it tonight a good time to discuss a serious issue. Now, you're going to hear a lot of points of view tonight. You're going to hear from patient advocates, politicians, consumers, and they'll all have very compelling stories to tell and issues to share, and they're going to try and sell you on their point of view, and that's great. You might even hear some rhetoric and some contradictory claims. That's to be expected in these complex issues. So what I want to do is start off the evening with just providing you with a little bit of context. So I want to give you a little bit of a background on how the health system functions, how much we spend, and the challenges that some policymakers face as they try to make really tough choices on funding the health system. Now, I think it's important to do this for a couple of reasons. First of all, it's surprising how little the public actually knows about the state of Medicare, what it is, how it functions. And that's true of politicians as well as the general public. That's not a bad thing. It's not a criticism. We have a lot of competing interests in our lives, and we don't tend to think of healthcare until we need it, and then we don't have time to study the system. So I want to try and give you some of that background. And I think having some of these facts will help you, for lack of a better term, call BS on some of the stuff that you're told on the campaign trail and otherwise. You'll say, hey, that's not the facts that I know. So I want to try and give you some really good background very briefly. And then I'll be, as I said, be happy to answer any questions. So first of all, I think it's important to know that we don't have a health system in Canada. We have 15 health systems. Each of the 10 provinces and 3 territories have their own health system, and they're they're more and more distinct over the years. There's also a federal system, and there's a separate workers' compensation system that we forget about. It's the only private health system in Canada. Now, the provinces are responsible for the delivery of care to most Canadians. But there are a few exceptions. The federal government is actually the 5th largest health system in Canada. We forget that. They deliver health care to Indigenous people, the armed forces, veterans, the RCMP, prisoners, and refugees. So that federal system is large and neglected. Each province has its strengths and its weaknesses. I'm not going to talk too much about the problems in the health system tonight because we only have 3 hours. But there are a lot of issues. Take New Brunswick, for example. I travel around the country. I get to compare health systems. New Brunswick is really strong in a couple of areas like paramedic care. It's known around the country for the quality of that. Extramural care, something you've pioneered a couple of decades ago, which works fairly well. But it has, on the downside, a real shortage of long-term care beds, which is particularly troubling in one of Canada's oldest provinces, probably Canada's oldest province demographically, and it has far too many ALC patients. And ALC is a term that health bureaucrats use. It means alternate level of care, and it means people who are living in a hospital because there's nowhere else to put them. Almost 1/3 of all patients in this province are ALC. It's a tremendous waste of money. It's a horrible way to live. Tend to come to this province to write stories about ALC here in Nova Scotia, unfortunately. It's a real problem that we have to deal with in our health system. Now, Medicare, everybody knows that term, but Medicare is essentially the name we give our public insurance system. So it's the funding aspect of it. Canada has a first dollar coverage of essential health care. Oddly enough, New Brunswick is one of the only provinces that actually uses the term, actually calls its health insurance program Medicare. Other provinces like Ontario calls it OHIP, in Quebec it's RAMQ. They all have different names. That word Medicare doesn't actually exist in legislation. It's just something that we use in our parlance in Canada. And we've used it since the 1950s. Now, the underlying philosophy is quite simple of Medicare. No one should be denied medically necessary care because they can't afford it. So that's a really great philosophy, but putting it into practice is difficult. What's medically necessary is a debate that we've been having in this country for 60 years, and we'll probably have for another 600 years. Now, in Canada, we have universal health care. That's a term you'll hear. Of the world's 33 wealthiest countries, 32 have universal health care. And I'll let you guess which one is not on the list. Well, the president's Donald Trump, if you haven't figured it out. So the U.S. doesn't have universal health care. It has 42 million people with no health insurance. In Canada, everybody has health insurance, and in most of the civilized world. Now, universal health care doesn't mean that all health costs are covered for everyone. Universal doesn't mean everything. It means the basics are covered for everyone. That's a really important distinction. And it doesn't mean either that all services are covered by government. There are many different models of funding universal health care. I just came from the Netherlands yesterday. They have a really good health system, but it's 100% private insurance. In that country, insurance is mandatory. You purchase it. If you can't afford it, the government will subsidize it for you. But that's universal, but it's a very different funding system from Canada. And of the 33 countries, there's probably 33 different ways of doing things. Now in Canada, Medicare only covers physician and hospital services, 100%. And that's for historical reasons. But over the years, we've done these add-ons that aren't officially part of Medicare, but that government covers. So government covers Canada-wide about 42% of drug costs, about half of home care costs now, 1/3 of long-term care, 5% of dental care. So Canada, what we cover is kind of all over the map. And this is very different from most countries. Most Western countries cover 80% of everything, from dental through to long-term care, physician care, and then you're expected to top it up with private insurance. So Canada has a very unique, it's called a bifurcated model. We have two different funding streams. One's 100% and the other one is all over the map. Last year in Canada, we spent $242 billion on healthcare. That's roughly $6,600 per person, or 10.3% of our gross domestic product. So 1 in every $10 in Canada is spent on providing healthcare. So it's a really important economic driver, a really important employer. 1.1 million people work in our healthcare system in Canada. And it's even more important in smaller, less wealthy provinces. It's really key to the economy, the health system. And again, we forget that aspect. So 70% of our health system, of our health spending, is public. That's $170 billion. We pay that with our tax dollars. The provinces fund the bulk of that through taxation, and Ottawa pays roughly 38 billion dollars of that amount. That's 21% of the total, and it does it through the Canada Health Transfer, health program that's a funding program that's been around for many years. Now, when Medicare began in the 1950s, Ottawa covered 50% of all costs. So this is an ongoing beef by the provinces that Ottawa has gradually covered less and less of health costs. It's down to 21%, as I said. So more and more responsibility falls on provincial taxpayers. And again, the way we fund healthcare, depending on provincial dollars, really puts smaller, less wealthy provinces like this one at a real disadvantage. You have an aging population, meaning more costs, and you have a shrinking tax base because the population isn't growing the way it is in BC or Ontario. So you have this double whammy of the impact of health costs, and it's really problematic. And to me, the role of Ottawa is to offset that with funding, and it doesn't do a very good job of it. In fact, in recent years, it's made the situation much worse. Ottawa changed the way it does transfer payments to purely per capita basis. So you get funding based on the number of citizens you have. You used to get funding based on the number of citizens plus demographic adjustments. So you would get more for more elderly patients, more for poorer people. And when that system was changed, again, provinces, the so-called have-not provinces like New Brunswick really took a hit from that. And the beneficiaries were the wealthy provinces like Alberta. And that, again, seems a bit perverse to me. Now, I talked about public spending. 30% of our health spending in Canada is private. That's the highest rate in the world aside from the US. So again, we have a lot of private care, and we don't recognize that all the time. Among Western countries, Canada is dead last in the proportion of public dollars that go to healthcare. Second only to the US when it comes to spending on private insurance and out-of-pocket costs. We're not a socialist country the way we tend to think or portray ourselves. We're very demanding of the public in health funding. So I think there's two things that you should retain from this data that I've bombarded you with, from these numbers. One is this notion that our health spending is out of control and gobbling up too many tax dollars. That really doesn't hold up to international scrutiny. Most other countries spend far more public dollars than we do on public health care, and they deliver care more cheaply. They just cover a much broader range of services for the same or less money. And you should bear in mind that Canada has the least universal healthcare system in the world. And that's not something to be proud of. We don't do a good job of covering the edges. A lot of people fall between the cracks. Again, the only country that does a worse job than us is the US. And we tend to compare ourselves to them because it makes us feel better, but it shouldn't make us feel that much better. You know, if you go, I just spent a couple of weeks in Denmark and the Netherlands, and the care there is so much more thorough and you know, it's about the same cost, but so much more is covered, and there's not the wait times, etc. We could talk about those comparisons for a long time, but that's who we should compare ourselves to. Now, I just said that health spending is not out of control. Now, that doesn't necessarily mean we should spend a lot more, and it doesn't mean that current spending isn't a fiscal challenge, because it is. And one of the main reasons it is we tend to undertax ourselves. We're obsessed with tax cuts, etc., which again is very different from much of the Western world. Now, New Brunswick will spend about $2.6 billion on healthcare from the public treasury this year, and that's almost half of all program spending. So that's a real hit. It's what politicians say is that the health system eats everybody else's lunch at the cabinet table. If half of all the money goes to healthcare, the other half is for everyone else to fight over. So that's problematic politically. Now, you're going to hear people tonight and people on the campaign trail say that the health system is unsustainable. That's one of our most favorite rhetorical phrases in Canada. And I think you should be careful about that kind of rhetoric, about what does it mean. First of all, you have to define what you mean by unsustainable. Do you mean it's unaffordable? Because that's a very different thing. Do you mean it's unfair? Do you mean that you're not providing bang for the buck? So be careful with that word and its meaning. To me, our health system is as sustainable as we want it to be. We have to just decide how we want to shape it and how we want to fund it. And those are political and social choices. They're not, we can't just throw up our hands and say, oh, it's unsustainable, there's nothing we can do. These are decisions that are made and should be made. And again, make no mistake, there are a lot of things that could be fixed in our health system. But the good news is it's all fixable, and it is all affordable. We have many other countries that can teach us that. And there's more than one way to do it, which is also important. It doesn't all have to be done through public funding and public dollars. Now, tonight you're going to hear a lot of people say that we're failing to provide a lot of things. We don't have adequate drug coverage. We don't have sufficient mental health services. We need more hospital beds. We need more doctors and nurses, and so on and so forth. There's some truth to all of that, but again, we have to make choices. Many of those demands will be legitimate, but when you hear them, you should ask yourself three questions. Do we really need more of the same, or do we need to do something different when it's not working? In Canada, we tend to just throw more money at problems. When something isn't working, we do more of it. And Einstein had a very good expression for that. He said, doing the same thing over and over and expecting different results is the definition of insanity. And that's, we do a lot of insanity in Medicare in Canada. Now, if we're going to spend more money on problem X, we have to ask ourselves, where's the money going to come from? There's always going to be trade-offs in politics and in economics. If we spend more on health, do we want to spend less on education or roads? Or paying people a decent living wage. We have to be more upfront about the trade-offs and the realities. We have to ask ourselves, what's the value of a new drug or service that we want? We tend to talk a lot about cost, but we don't talk enough about value. So I often say, you know, a $500 drug may be affordable, but not provide value. A $500,000 drug may seem unaffordable, but it can provide value. depends what it does and what other impacts and paybacks it has. So these are not simple questions. And I think another thing we have to ask ourselves that we don't often enough in Canada is, how do we say no? We're not very good at that. Medicare is not supposed to be an open-ended buffet, all-you-can-eat buffet. We can't cover every health service for every person all the time. But how do we draw the lines in the sand? That's one of the most pressing policy issues in Canada today. What's in our Medicare basket of services and what's not? Now, before I wrap up and take questions, I want to expand on one issue that's going to be a hot topic tonight, and that's pharmacare, drug funding. And pharmacare is also going to be a major issue in the next federal election. It's probably be an issue in your provincial election in a couple of months as well. In Canada, our coverage of prescription drugs is really a dog's breakfast. It's really all over the map. It's a patchwork of private and public insurance programs that serves some people well and serves many people badly. About 26 million Canadians have private drug benefits, largely through their employers. There's no single national pharmacare program, but there are 102 public drug insurance programs in the country. So a lot of bureaucracy there. Despite all these programs, there are still about 700,000 Canadians with no drug coverage at all, and an estimated 3.6 million who have inadequate coverage. And these numbers are from the Parliamentary Budget Officer. Now, the people without adequate drug coverage live quite disproportionately in this part of the country, in the Atlantic provinces. There are still people in this country today who lose their houses paying for their drugs, and they all live in Atlantic Canada. And that's the exact thing that Medicare was supposed to prevent. And that's, to me, it's a travesty that that still exists today. Now, New Brunswick, like most provinces, has a public drug plan for those without coverage. But the problem with it, and the problem with many drug plans, is that they tend to be expensive. The New Brunswick plan has premiums. They're income adjusted, but they still have some cost. Can be as low as $200 annually. But they also have significant co-pays. And you'll hear more about this later, but the co-pays can be about 30% of a drug cost. And although there are maximums, if you have a drug that you take every month, several drugs every month, the costs really add up, so it becomes unaffordable. So that's some real problems with drug coverage, especially in this part of the country. And this province also has the highest per capita private drug spending, so there's a lot of pressure on people to pay out of pocket. Now, finally, you're going to hear people say that pharmacare, having a national pharmacare program would save us a lot of money, billions of dollars. And yes, it has the potential to save money if it's done properly. But there's also some trade-offs that we have to recognize. Pharmacare, like Medicare, doesn't mean that every drug would be covered for every person all the time. In fact, public formularies, and a formulary is a list of drugs that are covered by an insurance plan, public formularies tend to be much smaller than private formularies. There's about 4,400 drugs on the public formulary in New Brunswick. There's about 12,000 drugs on the average private formulary. So it's great to have public coverage, but you may not get the drugs you want. And you're going to hear stories about this tonight, and that's problematic. Also, just as important as the potential cost savings are the shifting of costs. Pharmacare means transferring the cost of private drug plans from employers to the state. And we're talking significant amounts of money, $24 billion shifted to the public treasury. Of course, it would be the same amount of money, but do we pay it out of the left or the right pocket? But again, it's not so much the cost as the politics of it that's difficult. We don't have an appetite in this country for tax hikes. So imagine taking on $24 billion more in public spending. I'm not sure something like a singular national program would fly. And other people, I'm sure, will talk about this tonight. But there's a big discussion going on. Eric Hoskins is traveling around the country, getting opinions on where we should go with national pharmacare. And I know he was in this province just about a week ago. And, you know, it's not clear what he's going to propose and if what he proposes is going to be palatable and acceptable to the provinces. The provincial premiers met recently, and they were pretty hard line on pharmacare. They said the only way we'll get it is if Ottawa pays the whole bill and if we have an opt-out clause. So it's going to be a hard sell. So I'm going to stop there because I know I've used up my time. If I have some time for questions, I'll take some now, and if not, I can come back later. Anybody have questions, comments?
I have a question, André, since you've been around, you've been in New York and so on, you know what it's like in other places in terms of healthcare.
Oh, just use the mic because of the live stream.
Oh,
Sorry,
thank
people
you.
can't hear you.
So my question to you is, in Europe in particular and the Nordic countries, how do they address those parts of the bodies that we leave out of the Medicare coverage, so teeth and eyes in particular?
Yeah, so virtually every country except Canada, the U.S. covers the whole gamut. So if you go to France, the Netherlands, Germany, dental care is covered just the way our doctors and hospitals are covered here. But everything's covered. So I was in France. I was just in France before, the Netherlands. 85% of everything is covered, and then I have to top it up with private insurance. So if I go to the dentist, it's not like here. I pay on a $100 bill, I pay $15, not 100. So everything's covered, but the difference is you go to the doctor in France and you also have to make a co-payment. But everyone there, 100% of people have private insurance to cover that difference. So the philosophy there is universality means that everybody has care, but everybody has to make a contribution if they're going to appreciate it. So that's their philosophy in European countries. But yeah, it is problematic in Canada that, you know, our system is created in a way that the mouth is not part of the body. And dental care is a real big issue for a lot of people that can't afford it.
It is, and I ask it because, you know, as an MLA, and I'm sure Mr. Bork as well has experienced this, is you have constituents who have serious problems around their mouth, and there is this line, you know, over which it becomes covered under Medicare and under which it's not. Yeah. And people can be in extreme pain and discomfort, and anyways, it is a challenge, and so I was interested to know what they do elsewhere. Thank you.
Yeah, drawing those lines is difficult in every area, but definitely in the dental care area, the line is at the wrong place. You have to be so severely ill that you need surgery in a hospital to be covered, and people shouldn't have to degenerate to that level.
Since you referred to Scandinavian countries and Northern European countries, one question I'd have for you is, as Mr. Kuhn was just mentioning, sometimes, you know, the line is kind of blurred. Okay, do we cover, don't we cover? It's kind of like, it's a tough question. What I would like to hear from you is, let's say that the provincial government would like to be bold in some way in the future and do, let's say New Brunswick chose to do something very different, to kind of rock the boat a bit and say, okay, we're going to try something completely different. Not adjustment, nor ne pas fignoler les choses, mais faire un changement important. Which, from your own view, which health system portion of another country should we be particularly interested in terms of it might offer something quite interesting for us?
Yeah, I often get asked that question. I think we have to be careful with this notion that we could just import a magical solution from somewhere else, because healthcare is very cultural. So we have our whole culture and history that has given us this quirky system in Canada. The Netherlands has its own history and culture that it's given it its own quirky system. So I think you can't just throw things in. So I think what's more important is to take ideas. And I think the idea that we can take from Europe, I think there's two main ideas. One is this notion that of shared responsibility, that the state covers a lot, but everybody has to make a contribution. So we make this, in Canada we have this weird, why are hospitals and doctors different from everything else? Why do they have to be 100% covered? There's not really a good argument for that, and it doesn't exist anywhere else. I think we can learn from that. And, you know, I'm not saying privatize everything, go crazy. That's not what I'm saying, but I'm saying have this more of a mixed model across the board instead of our bifurcation, these two different camps. And the other part I think we can learn from Europe is that they are more interested in health than medicine. So they spend a lot more on the things that really keep people healthy: education, housing, you know, income supports like welfare. They spend a lot more money on that, and there's no shame in it. And they spend a lot less on healthcare as a result. So in Denmark, where I was last week, 27% of the gross domestic product GDP goes to social welfare programs. In Canada, it's 13%. Conversely, we spend almost 11% on healthcare. They spend about 7%. So you spend the same amount of money, but you spend it differently. And I think they have more of a social justice approach. We're going to spend on keeping people healthy and part of the collectivity, and not wait for them to get sick and treat them. So I think those are the two big lessons we can learn, rather than try and import any given system. Yeah, she'll just bring you the mic.
A little off topic, but before I make my point or question, I was a subscriber for 30 years, and very, very disappointed that your paper is not available in our market anymore, because it's very insightful, and your column it was awesome. That said, in terms of pharmacare, I'd like you to expand a little bit on your comments that you made at the end, and talk a little bit more about the probability and the pros and cons as you see it for a small province like New Brunswick.
Yeah, so the first part, I travel around the country a lot, and I hear these complaints about the Globe, and I bring them back to our publisher, and he, takes them as he takes them, but I appreciate you saying them, and as someone who loves to read a paper, I would be shocked myself, but I can't do anything about it. So the second part, I think, pharmacare, I think it's something that's overdue and necessary, but I think we're kind of stuck in this notion that it has to be one massive federal national program, and to me that has zero chance of happening, especially given the political realities. Ontario won't accept that. Quebec won't accept that. Quebec also already has pharmacare. It's the only province that has universal pharmacare. Not the best system, but it's a start. I don't see Manitoba doing it. None of the conservative provinces are going to sign on to this. So I think it's a non-starter, a national single program. Unfortunately, a lot of the media, the voices in the media are a small group of people who keep selling this as the nirvana. It's going to save billions of dollars. It's going to be magical, and not talking about the downsides and the difficult political realities rather than the economic ones. So I think it has very little chance. I think Dr. Hoskins, what's interesting about his exercise is that he started talking just about a universal single payer program, and now he's talking more and more, I think, realistically about a mixed model. Now the question is, what kind of mixed model do you want? So again, if I look to European countries, something I obsess about these days because I think they have lots of lessons for us. Most of them have a law like Quebec. You have to have drug coverage. You have to have drug insurance. It's mandatory for everyone. Your employer has to provide it. If they don't, if you can't afford it, the state will subsidize it. So that's what you do. That's the important, and that's what Quebec does. And then what European countries do that Quebec didn't do is they legislate caps. So then they say the maximum that a company is allowed to charge is X. No one is allowed to be refused. I think that's a real important part of the law in most European countries that Quebec doesn't have. An insurer shouldn't be allowed to refuse anyone. And that's what makes it fair. So it's all about regulation. The devil is really in the details. So I think you can achieve everything that you do with a national plan and do it more efficiently and more politically palatably with more of a mixed model.
So. You certainly have opened up my eyes. I'm sure we could spend the night. I'm sure there's a lot more questions. Unfortunately, because of our time, we need... Yes, Rose? Oh, okay.
Okay.
So we received a comment via live stream from Sharon Buchanan from the People's Alliance in Albert. She says, "It seems to me that at least a part of the issue is not the amount spent, but the way in which it is used. Example, having after-hour clinics that are open 3 hours a day does little to alleviate the 8 to 10-hour wait on an overused emergency rooms. Preventative medical coverage, eyes and teeth early can alleviate more costly and long-term chronic conditions later."
Yeah, so very good point, and it comes back to what I said before. We obsess a little bit too much about what things cost, and we don't think enough about the value. So where's the best place to, emergency care is always a big issue. What's the best way to do it? Is it to send everybody to the emergency room and wait 8 hours? Is it to have expanded community clinics? Is it to have home visits? All different countries have all of these models. What's unique to Canada is we have waits that are untenable compared to the rest of the world. So in Canada, people can wait 24, 36 hours in an ER. Again, when I was in France, 1% of people wait more than 4 hours in the ER. And when they do, it's a gigantic scandal. So it's about a culture. We tolerate a lot of mediocrity in our health system in Canada. We're too willing to accept the unacceptable. So it has to be part of culture change as well.
Sure, and just one last, if you can answer this one quickly, Andre.
Yeah.
We had a question, how do European countries address the possibility that co-payments and top-up insurance become barriers for some vulnerable groups?
Yeah, so again, it's there's means tests. If you can't afford something, it's say you're in the Netherlands where it's private insurance. If you can't afford it, the state will subsidize it. So they'll pay your private insurance, they'll cover your co-pays, or in some cases they legislate that for certain people you can't have a co-pay. Co-payments are not very common in European countries. It tends to be just coverage. It's mandated, and then there's limits on what you pay. So co-pay is a very North American thing. Okay. Thank you. Look forward to the evening.
Merci beaucoup, André. So now we're going to go into the second part, I guess, of the groups of speakers, and we'll be meeting 3 individuals who have lived their own experience in the medical world. And the first person that I'd like to introduce you to is Terry Jaillet. Terry's been fighting melanoma since 2009. Since then, he's had several surgeries, one just recently, I think, a few weeks ago, from what I understand. Taken drugs by injection, has undergone 4 doses of immunotherapy. In December 2014, he started the new BRAF-MEK combination in Montreal, which continued until February of this year. On March 21st of this year, he started a new combination immunotherapy. Plus, he's currently being followed by several doctors in North America. So, even though his journey is ongoing, he remains hopeful. So I'd like to introduce you, Terry Jaillet.
So, hi, my name is Terry Jaillet. I'm from New Brunswick, and I've been diagnosed with melanoma in 2009 and been fighting it ever since. So I would like to share some details about my experience from being diagnosed in 2009 till now. I believe I want to point out some shortcomings in our New Brunswick healthcare system that hopefully in the next provincial election after the new party gets in, that they'll be able to help promise to fix some of those things. Sometimes I'll look down because I'm not as good as that guy down there. My problems first started when I was first diagnosed in 2009. I went to an after-hours clinic and I showed him a mole on my toe that was damaged and was not getting healed. So the doctor at the after-hours clinic told me that it was fine, and she wrote down the name of it on a piece of paper and said that I'll refer you to a dermatologist and we'll be able to fix that. So there's no worries. So what had happened is there was a delay about 2 months before I got to a dermatologist because it wasn't serious, and found out that he did a biopsy, sent it away, and found out I had melanoma. So almost 2 months went by where I didn't get any surgery or nothing, and I had melanoma. So once I got the, I've got to go back a bit. Once I got the dermatologist, he immediately took the biopsy and referred it to a surgeon so that I could have my mole removed completely with safe margins, is what they call it. So one thing that happened is the doctor who did the surgery told me that at the end said that we took all the melanoma out and you'll be fine and no further treatments will be necessary. So at that point I thought, shoot, I'm cured. That was a joke I threw in. So I thought, well, that's great, I'm cured, so I don't have to worry about it anymore. Like, they never talked about anything. So I gotta take my glasses off. So 2 years later, in 2011, I discovered lumps in my groin area and went to my doctor, and to my surprise, I had melanoma again. So it spread from my foot up to my groin area, which was your lymph nodes. My lymph nodes were removed, and the doctor here in New Brunswick said, we're going to do radiation next. So I was skeptical about radiation because I was on the internet researching it and thought, I don't know if radiation's really the treatment I should do next. So that was the point where I left New Brunswick and went to Quebec City to see a doctor and brought him all my information that I had, CT scans, etc. And they told me that radiation was not the next thing you should do with melanoma. It should be to take interferon for 1 year and not to have radiation because melanoma cells respond negatively to radiation. So the good thing is I got referred to a Quebec City doctor and I got a second opinion. A year and a half later, in 2013, my cancer returned. I went back to Quebec City and told them I had tumors in my leg starting to spread cell to cell from where it started. And they told me to have surgery to take it out and have an MRI. So I was never prescribed an MRI in New Brunswick up to that stage. And when I went to Quebec, I came back with a prescription saying I need an MRI. So thankfully, I had an MRI because I had a tumor in my brain. So that would have went on for till probably I would have had a seizure and fell down, and they would have probably did an MRI on me. So at that point, I went to a neurosurgeon in Moncton, and was told the only surgery I could have was an invasive surgery where they cut your head, take the tumor out. So that's what I did, because again, I was researching, but not as much as I do now. 3 months later, I had an MRI, and they found another tumor in my brain, and I went back to the same surgeon in Moncton, and he told me that it was in a risky location, and I wasn't comfortable doing the surgery, so if you want the surgery, come back to me, and maybe I can do it for you. So I left the office. This was many years ago. I'd never been back to the office. I went to Quebec City again, and within a week I had 2 tumors removed by non-invasive radiosurgery, which they did right in Quebec City. So I went there, and a week later I had surgery, and they removed the tumors by radiosurgery. So as time went on, I was getting more lumps in my leg after radiosurgery. I started to do more research on the internet. Through Facebook, I had found a celebrity that had the same thing I had in the United States, and was telling them as I was going what was happening with me. He referred me to, he says, Terry, go see a doctor. He's one of the best melanoma doctors in North America, and he's in Los Angeles. So he gave me the name, he gave me the secretary's name, who to call, how to ask for an appointment, and I did exactly what he said. So I went to Los Angeles. It was a 2-day event. I went to a symposium, which was not only to doctors and nurses and caregivers, it was also to any patients. So I went to an actual symposium in Los Angeles, and the next Monday I went and saw the doctor, and he told me I needed systematic treatment right away, or my tumors were going to keep coming back as I took them out. So he knew that in Toronto they had a clinical trial with immunotherapy, that I could go take that. He actually called the doctor, left a message with him, and I don't know what happened with that. But as I returned to New Brunswick, it was actually just approved that immunotherapy was approved in New Brunswick that I could take. So I took the immunotherapy in New Brunswick, and after immunotherapy I'd had an MRI. It looked like things weren't getting better, but I felt like I needed to continue with systematic treatment. So the next systematic treatment was combination targeted therapy, which she mentioned, BRAF and MEC. And the clinical trial closest to Moncton was in Montreal. So I went to Montreal, saw the doctor, and within a month I was taking a clinical trial for targeted therapy. Within 9 months after immunotherapy and 5 months after targeted therapy, I had complete response in my brain and stability in my leg. I only had 5 tumors left. And that was in 2014, I think it was. 2 years after the clinical trial, which I had to travel to Montreal every month to see the doctor, to get my medication, but also to have MRI, CT scans every 3 months. But every month I had to go to Montreal with my own, I had to pay for all the flights and hotels, etc. So things were stable, and 2 years later in New Brunswick they approved the second drug of immunotherapy, or targeted therapy, excuse me, so I could actually quit the trial and start taking the drugs in New Brunswick with my Blue Cross system. So I did that, and then in February 2018, it was almost 3 years after taking targeted therapy and I had taken the immunotherapy, some tumors started to come back in my brain, which was complete response after the 5 months and 9 months. I think 5 months and 9 months started to come back in my brain. So since February of this year, I started getting the multiple tumors. I needed a new treatment. So advice from the doctors that I have in Quebec City, Montreal, and Toronto, which I have doctors at all those 3 cities, including Los Angeles, the combination immunotherapy was the drug that I should take next to try to get into the brain and also help with my other tumors. So the combination therapy I took, one drug was approved in New Brunswick and one drug wasn't, so we got the drug company to pay for one. So I started taking the therapy in March of 2018, and since then I had to be off the drug because I had colitis and a lot of other side effects, which are very big side effects you can have with taking 2 immunotherapies. And in this speech that I wrote, things have changed a little bit since. I now can start the second immunotherapy drug that was approved by the drug company to give me for free. And I also had radiosurgery in my brain in Montreal instead of Quebec City because they have the newer machine in Montreal. And I had 5 tumors. It's called a gamma knife, where they go into your brain and basically cut the tumors out, but they stay there and they eventually disintegrate. So that changed since my speech. So things keep going along after 2009. So my experience is not unique, probably in New Brunswick or probably across Canada. I've been fortunate enough to have the Save Your Skin Foundation, which was next to my name. They've been with me since 2011. I contacted them to ask for help, and they've helped me. Also, the National Patient Group for people with skin cancer, including melanoma, has helped me. My oncologist in Moncton has been working with all my doctors in Quebec, Toronto, and Montreal by phone calls and sending reports to them. So they've really helped me a lot here in Moncton. These doctors have been amazing and helped my NB doctors manage my care since 2009. So what does this mean for the New Brunswick election coming up? I wrote down 5 things that I felt could be changed. So from my experience, the NB healthcare system and the new government that's going to get in could commit to these 5 things. So I'll just read these 5 things that I have here. We must provide resources for continuing medical education so that doctors learn about new medical conditions, new information about medical conditions, and new treatments and diagnosis for different types of things like melanoma. The second thing is we must provide resources to redesign our diagnostic and treatment continuum to a team approach where different medical specialties can work together even from different hospitals to work together and not just solo. They can work together and help each patient differently. We also need a commitment that innovative drugs required by people in New Brunswick are available when required, both before they are approved and general reimbursement for people who cannot wait for them to be approved through Compassionate Access Program, and then by early review for reimbursement in line that other provinces do in Canada right now, which could have helped me along the way as well. Instead of traveling to Montreal every month, I could have got the drugs approved here and started taking them. And two other things is we must have a commitment to provide resources to bring clinical trials to New Brunswick so that patients like myself don't have to travel out of province, incur an additional out-of-pocket expenses like hotels, flights, meals, etc. We have 3 large cities in New Brunswick that we could get together and work together to have clinical trials brought to New Brunswick. Because today we have small hospitals with small populations, and to get clinical trials here is not affordable for these drug companies to come here. So if we can get everybody together, we could get clinical trials in New Brunswick, which would help the New Brunswick government because these drugs would be paid for instead of traveling to Montreal or Toronto. So similar to the above, I also put on my speech here that the new Cancer Research Center that they just built in Moncton that's not open yet could be a great opportunity for New Brunswick to bring clinical trials here in a central position for all of the Maritimes. We could have Halifax, Nova Scotia involved, PEI in New Brunswick, and the drug companies would just have to come to the George Dumont, set up clinical trials for all of those people. So to travel from Halifax to Moncton would be very easier than going to Toronto or Montreal, because that's the experience that I went through traveling all around Canada and Los Angeles, but only once I went to Los Angeles. It's nice there. I would go there for a trial. So that's the 5 things that I suggest with the next government that gets in, and I think would help a lot of patients. Clinical trials can save people's lives. You can get a lot of times you can get the medication for free from the drug companies till they're approved in New Brunswick. So I think it's just a great opportunity for the future. So that's it. Thank you. Did you raise your hand yet? No? Oh, okay. I didn't. I wasn't staring right at it because these glasses are for close.
Thank you very much, Terry. If one word comes to mind, you can have a seat right here because we're going to have Linda join you afterwards, or Jacinthe join you afterwards for a question period. So one thing comes to mind with Terry is persistence and passion to get to the bottom of things. So thank you very much for sharing your story. Our next person that will share her experiences is Jacinthe Brault. If you would have asked Jacinthe Brault on this day 10 years ago how she imagined herself 10 years in the future, the picture painted from her hospital bed on the psychiatric unit of the Dumont Hospital would have been quite bleak, if even conceivable. Her journey as a patient, a client, and for the past year a certified peer support working in community mental health services has been filled with challenges, but also opportunities to confront biases of what it means to live with mental illness. Jacinthe believes recovery-based approaches help those suffering connect, find hope, and regain mental health, and so much more. Please join me in welcoming Jacinthe Brault.
Sitting down with clients, so for me it's more a natural there you go, setting, if that's okay with you. All right, so thank you very much for having me. Thank you very much for having me here with you tonight. Like was mentioned, it's pretty special for me because I was actually admitted to the Dumont Hospital on July 29th, 2008. So I've been celebrating with my colleagues in the past couple of weeks, and they know about this. I've told them, and it really is a celebration because honestly, when I was in that hospital bed, I had just no clue how I would ever, get out of there, and what would my life be like from that moment on. So if I start from maybe that experience of being hospitalized, it was very difficult for me to be there because that wasn't part of my life plan. That wasn't. Thank you very much. That was part of my family's history. That wasn't something that I had in mind when I went to university and graduated in communications and started working in public relations. That wasn't part of it at all. Sorry, actually, none of it was part of it. So I can say that I was in shock and denial, like many people who have this first experience. And that lasted for a while, actually beyond the hospital, going back home, trying to just make sense of what had just happened to me. And yeah, it took a long time. There was a lot of despair and feeling that my life was over, that my life was going to be very limited from this point on. And this was despite my psychiatrist's best, attempts to kind of encourage me through this, but it was very difficult for me because my scheme of reference to mental illness was a very dark one. There was actually no one in my family who suffered from mental illness who had returned to work. So to me, I was just thinking, I will no longer be a productive member of society. This is really the worst nightmare, that I could have imagined. And then somehow, it took a while, but there was opportunities. There were challenges, but there were also opportunities to connect with other people who were going through similar experiences that I was, feeling side effects from medication. I'm thinking about actually CMHA support group, which was a very big part of my recovery. But just having space to speak about what I was going through was a big, big part of kind of gaining perspective, healing, feeling maybe a little bit more empowered, feeling like maybe I had something to say, and then starting to collaborate more with my psychiatrist on adjusting medication and tweaking some stuff that, eventually made a very, very big difference for me. There was a period in my life in those 10 years where I was no longer able to work. My psychiatrist was accompanying me through this, but we were both at some point at, this might mean permanent disability. And this was not that long ago. We're talking about, 4 years ago. So this year, celebrating this landmark for me is even more important, especially since now I'm working in the field and helping other people see beyond their present life circumstances. And for me, that's what is so important in our mental health system, to help people see beyond, not through our eyes, through their eyes, but just to try to help them take away that veil that we all feel when we're in that position of feeling so vulnerable and our dignity is, kind of stripped from us, and just gaining that back is incredibly empowering when you've got someone next to you saying, you can't see this right now, but you've got everything inside of you to make this a different experience, a different situation. So that's been my experience. I'd just like to touch lightly on lightly. It was actually a big part of the challenges, I would say, with the question on the medication that André talked about. My experience was actually I don't know if it would be different, but when I was no longer employed, I couldn't benefit from the New Brunswick drug plan because it wasn't in place yet. So at one point I was paying over $300 for my medication because there was one in particular that was not covered. And even though I knew that was the case, I believe that it really made a difference in my treatment, in how I felt. And I decided to continue to basically to pay it, out of pocket. But that's because I had support from family, and but definitely that element is can be a challenge. And even with the drug plan, I think when I finally applied for the drug plan, it was about a $20 difference from what I was paying out of pocket. So, there's definitely, I'm not saying it's the norm, but I'm just saying that there's some elements definitely in there where some exemptions, are would help to cover the cost of medication. That is helpful, but again, it's what is considered at that point, to be eligible, I guess, in the list. So I guess I just wanted to say about the just kind of the elements to focus on in this election for me is to come back to the action plan for mental health in New Brunswick. We have one, which is fantastic. There's a lot of work that has been put in this plan. It was a plan from 2011, 2018. I guess what I'm wanting to see is a little bit how we're going to move forward with this plan, and especially with what pertains to an individualized approach. So we're talking about a recovery-based model of practice. So we're not using a cookie cutter, but we're really working with people on their individual needs, and enhancing knowledge. Actually, Terry talked about that, how we don't know really what's going on, especially at the beginning, and it's such a important time. And I think so many people would benefit from a better understanding of what is recovery in mental health and how it's possible. Because that would have definitely, from my hospital bed, probably, well, I don't know if maybe then exactly, but, shortly after, that would have probably a little bit, shed some light on a circumstance that for me was very, very, very dark. But I'm very happy to know it now and to share it. So I think just to kind of have those conversations, and also definitely family members, workplaces, community, we need to really grab this together, because this affects us all. We all have someone in our family that's suffering from some type of mental health disorder, and when the person is in a situation where they're trapped, we're all trapped, because we're trapped in our relations with this person, and what that person needs the most at that time is connection. So if we just as a province, as a community, learn more how to make those connections, I think that would also help to keep us all together, and not have people kind of at some point kind of décrocher, like we say in French. It's like to kind of disconnect, to kind of and I think that's pretty much it. That's what I had.
Merci beaucoup, Jacinthe. Thank you for bringing your heartfelt story and connecting with the folks here. We have one third person joining the group here, and that would be Linda Wilhelm. Linda is the president of the Canadian Arthritis Patient Alliance, a national grassroots volunteer patient-driven organization. Linda is a member of the Drug Safety and Effectiveness Network Steering Committee, co-chair of the Chronic Pain Research SPORE Networks Steering Committee, and a member of the Patient Engagement Committee. Linda has been living with rheumatoid arthritis for 35 years. Welcome, Linda.
Except I'm short. There. Wow. I've been living with rheumatoid arthritis for 35 years, and it's hard for me to separate the patient living with rheumatoid arthritis from the patient advocate that I became 15 years into my disease process. So I'm probably going to do a little bit of what I'm supposed to touch on next in this kind of talk as well. I've been in New Brunswick now for 32 years, so I've been here for most of my disease process. And I began as a patient advocate, advocating for access to biologics for rheumatoid arthritis, ultimately inflammatory arthritis, and then ending with advocating for a New Brunswick prescription drug program for people who didn't have insurance. And we got that. I did a lot of provincial work at that time, and then I got kind of pulled into some of the national scene of some of the work that I've been doing nationally with the Chronic Pain Network, some of the Health Canada expert advisory committees, and the different things like that. We do have a catastrophic drug program in New Brunswick. I know they call it the New Brunswick Drug Program, but as was touched on here, it really is catastrophic. I am a high-cost drug patient. I'm on a biologic. But without my biologic, it's actually cheaper for me to pay for my other drugs out of pocket than to pay the premiums and the co-pays in the drug program. That's my reality. My husband worked at the potash mine in Sussex that closed 2.5 years ago. So we had insurance until December of 2017. I went to apply for the New Brunswick drug program, but they would not they wanted to base my premiums on when he got his severance package in 2016. He was at the mine for 26 years, so it was a fairly good severance package. The girl I spoke to said, well, you should wait till you get your notice of assessment from filing your income tax, which I couldn't file until I got all my T4 slips end of February, March. So I ended up getting compassionate coverage by the manufacturer for my biologic, and then have just in the last month or so finally applied for my New Brunswick drug program, and I should, with my biologic, it is catastrophic. It will help me. It'll be a significant chunk out of a retirement income. Even at that, I know, their income is, for low-income people, it works very well. If you have high drug coverage, you can do it. And as Andre alluded to, we should have to pay something for our health care, and so I will do that, and that will be my contributions. But I will say that without this drug, without the coverage, I wouldn't be standing here today. I would have either spent the last 20 years in a long-term care facility, or I wouldn't be here. I wouldn't be alive, because when I got the drug, I weighed about, I'm not very big now, but I weighed about 85 pounds back then and was wasting away. The drug, the biologics were miraculous for me. I had been in the hospital for 3 months at the Chalmers Hospital, and with this drug, within 2 weeks, I walked out of the hospital, even though I hadn't walked in over a year. So for me, these drugs were dramatic and life-changing, and actually probably saved the government a fair amount of money, because my husband's insurance picked it up for the next 20 years. So, as far as cost-wise, I was fortunate that way. But I did go on because I didn't get the drug early enough in my disease process. If it had just come 5 years sooner, maybe, I might have avoided a lot of the damage that you see here. So I have had 14 total joint replacements or fusions in the last 20 years. Some of them, the joints are still wearing, so I had a hip replacement as early as about a year and a half ago. So I'm still living with this disease, but I am mobile. I stay active. I am involved. Every once in a while, the disease stops me for a while, and then I pick things up and I get going again. Hopefully the application to the drug program will go through with no issues, and we can just kind of move on from there. But if I'm going to say about what I want the next government after this election to focus on is patient engagement. I think our province, and we've heard it kind of talked around, but listening to the patient and engaging with the patient. But our province doesn't do a good job of it. They don't have Ontario and BC where they have a dedicated patient engagement committees that advise the government on drug policy, for instance. As patients, we've got to have those conversations. We've got to start talking about value of medicine. And to have those conversations, you need to bring patients to the table too. We can understand that, what medications that aren't going to cause cost, that aren't going to bring value to society, to the system, then perhaps maybe they shouldn't be covered. That there is this finite amount of money, and that we can't put everything into health and then not educate our children and our grandchildren. We can have those conversations too, but you've got to start bringing us into those meetings and into some of those conversations so that we can contribute. Even around, I've been involved a little bit around the opioid policy and chronic pain at the federal level with Health Canada. And I think that provincially we need to bring patients into those conversations. Often I see that you've had a meeting, but it's with physicians and it's with the regional health authority people, but it's not with the actual patients. And I know the regional health authority people, they have patient advisory committees as well, but they aren't reaching all the patient groups. And I know that was one of the frustrations and why, and I'll talk a little bit maybe later about why I became involved with the Canadian Arthritis Patient Alliance, which is a volunteer organization. We don't have any staff people. We are people from across the country on our board, all living with inflammatory arthritis, that volunteer our time to try to help other people with arthritis. And we've actually got the attention of the Canadian Agency for Drugs and Technology on Health for some of the materials that we have developed for patients around methotrexate, the most common drug for RA, and people that need to take those medications that maybe are older, that have been used for 40 years. That's maybe that drug will work really well for them, and they don't have to take the costly drugs. And make sure the patients but need the costly drugs get the drugs. And I'm going to stop there for now.
Thank you, Linda. The Canadian Arthritis Patient Alliance is lucky to have you as an advocate. I can see why you're part of that. Now we're on to another question period for these three individuals. If anyone in the room has a question, or if anyone online, live stream, if you want to send an email with any questions, I'll hand it over. Rose can hand the microphone to anyone here who wants to ask a question.
First of all, I would really like to thank all of you so much for sharing these stories, and also for contextualizing them in a systemic way so that we can give some advice to our political colleagues who were kind enough to join us tonight. One thing that I kind of heard from all of you in different ways was about the costs that you actually paid out of pocket that people don't seem to be take into account. So I know, Terry, you correct me if I'm wrong, that you've actually paid for most, if not all, of your travel and related expenses to get your province coverage, even though I know it was fun to be in Los Angeles and all that. And that must, that's big expenses. And you talked about the fact that the only way you could really pay for your medications was because you had family support. So I bet if you didn't have family support, you'd have been choosing between your medications and eating that week. And I know, Linda, you also are paying out of pocket for things until the government can cover them. So I guess, that's a theme for me. We often hear, I hear it certainly where I come from also, and I'll tell you where that is later, but is like, oh, don't worry, we have coverage. But people don't understand that there's so much more to it than just simply taking a prescription to a pharmacy that's related to good health and treatment. So I don't know if you have some specifics asks other than the ones you've already made in relation to all of that, but it seems to me that's a big piece that you've all really touched on, but no, we really, I think, have to point out that you were fortunate, you're fortunate that you had family. You're fortunate that somehow you could pay for that. And you've been, fortunate, and don't take me wrong when I say fortunate. It's only relatively fortunate. But, what about all the people who would never have gotten that treatment and wouldn't have been able to, I think that's a thing that I'd like to talk a little bit more. I guess it's what Andre talked about to an extent of the social determinants of health.
I'll hand the mic over here if anyone wants to answer.
Well, a real specific one. That when a situation happens like mine, where there is a mine closure and everybody's laid off, and some people take a package, that the government actually can look at that. I know they can't estimate in advance what your income's going to be, but they can certainly say, okay, I'm pretty sure he's not going to make $250,000 as a retiree from his pension, and maybe just have a little bit of flexibility around that in the future so that people can seamlessly continue their medication.
Yeah, I think flexibility is a good word. I think it comes back to the idea of individualized care and being able to look at individual situations. But definitely, when you were talking about that, I remember because I was no longer working, I had to move back to my parents, which is not great when you're in your 30s. It's really not. And you've been independent all your, so, but it's just when I think of people who, sometimes we hear about people who, quote unquote, choose not to take their medication or don't adhere to their medication treatment. I always think back to that because I think, like you said, I was fortunate. It could have been easy for me to, make a choice to not take this or this, but, I didn't. But I can understand that some people would, So, yeah, I think the flexibility piece definitely to kind of consider all the elements of the person's situation is important.
Yeah, I agree with all that, and also I did a lot of I'm like a research person. So in Quebec City, when I go there, I stay at, just to give an example, I researched and found out you could stay attached to the hospital in Quebec City, the Hotel Dieu du Quebec, for $17 a night, and you get 3 meals at the cafeteria. So I thought, geez, that's pretty cheap. I wonder if my wife will stay with me. No. But anyways, I go there, I stay with, but I have to be with somebody else, which I'm there for doctor's appointments, or actually 3 times I had radio surgery there. But anyways, it was a good experience. I always got to meet other people that were going through problems as well. And sometimes I got, when I was on the clinical trial, for instance, in Montreal, I got, but you have to ask. If you don't ask, you don't receive. So I asked the drug company, I said, can they pay for my hotel? And they said, yeah, we'll find out. And I had to ask 3 times to the nurse, the head nurse, and the 3rd time they said, yeah, they'll pay for your hotel. So I put in all the hotels. So there's things you can do, but you have to know how to find these things out. When I went to Toronto to have radio surgery in Montreal to have radio surgery last month, I think it was last month, 1st of July, I stayed at the Canadian Cancer Society. It was $50 a night. You get 3 meals a day. They always had rooms available. And Toronto this time of year in July would be crazy. It would be like $250, $300 a night. So there's things I've learned. I'd like to give that information out, but I think the cost of going to get these treatments is very expensive. My family stood by me. And it's hard. I got a son with autism too, so I got that problem as well. So I mean, we got a lot of things going on in our life. So, but I did it all. If I didn't do it all, I probably wouldn't be here today. So, anyways, that's my thoughts.
Carolyn, I do have a question from the live stream, and it's on mental health. Just give me a second. Mental health is clearly underfunded compared to the burden of disease. Will the government commit to additional funding for mental health and into community-based programs? So that's not necessarily a question for the patients, but we'll park that one for later.
What do you think they should?
Well, I mean, obviously, I think there's a need. There's a definite need. There's a need for beds. There's a need in hospital. There's a need in care homes. There's a need. There are needs, but there's also, I think, a lot of things that we can do differently and be more creative in the way that we provide care and support that I think can go a long way in helping people kind of gain that, ownership of, okay, I'm going to find out about this illness and I'm going to be an active participant in my own recovery. That actually is probably, anyway, in mental illness, that's the most important thing, really. Right, yeah, absolutely. So that, I think, is the most determining factor, and if we can find a way to I can't find the word right now, but it's like the levier, to find the switch to kind of, help people to kind of, take that ownership. I'm not saying it's all their responsibility. We have chronic illnesses. We didn't ask for this. This happened, but the fact of being in a position where you're able to know what you're dealing with and feeling like you're part of the process of the treatment and that you can have access to the medication, all of that is a big determinant in how you're going to deal with this day to day. So.
I noticed a few themes, I guess, amongst all three, and my points may focus a little bit more on mental health, but I think the crossover themes, I'd be interested to hear if any of you have, some points or thoughts on what could be done or asked. In terms of mental health, we have seen mental health, what we call significantly underfunded, but and the use of funds, I know we've talked about that, and some of the use of funds are going into a lot of intervention as opposed to prevention, and looking at the way of how can we use what we're doing and shifting those resources. And I know for all three of you, you talked about some of the importance of prevention and awareness and focusing on some of that well-being. In the way that mental health is treated in the system versus physical health, if you look at the psychiatry services, oftentimes individuals who are hospitalized are put in positions where they have to earn privileges while in a psychiatric unit. So earn privileges to use a phone or earn privileges to use other things while undergoing different treatment. And I know social connectedness was something that you had brought up as well. The cost of medication, we've had clients indicate the cost of medication up to $800 a month, which puts individuals in a position where they have to choose between rent sometimes or feeling well. In terms of work, we, Canada-wide, we see about 500,000 Canadians miss work each week because of a mental health concern. and individuals often have physical health sick days but not mental health sick days. And in terms of treatment, the wait lists for treatment. I know, Terry, you talked a little bit about having to wait a couple months, and individuals reaching out for services for mental health as well often end up having to wait up to 18 months sometimes on a wait list if they don't have access to EAP programs or healthcare benefits to cover services that way. And in the meantime, we end up seeing presentation at the ER or other services, or we see physical health crisis present at the ER. So I'm just curious if of any of those points, any of you might have some recommendations that way.
And I mean, it's the same for patients who are with chronic pain, living with chronic pain, to access the multidisciplinary pain clinic. I'm not even sure if we even have one in New Brunswick. If we do, if they're still waiting, the wait list, I know they weren't even taking patients a couple of years ago because the wait list got so long. And, you know, it's one of the things that comes up a lot with the opioid discussion as well, the wait list for chronic pain and the relationship between that. So.
Yeah, again, I think I'd just like to mention when you talked about, you know, access to services. I can give another example that I think illustrates. There were 2 times when I asked for services at my community mental health where I now work, and the first time around it took almost a year. And the second time around it took almost 2 years. By that time I had access, you know, private services, again with help of, you know, family, and but this is real. The wait time is very real, and we're now in a situation, I think, also where people know this, and now, you know, you've got people questioning, well, should I actually go in because I know that there's this long wait, you know, so it's affecting also just people's perception of should I actually even access, you know, try to access the services, which, you know, they should freely, you know, go to if they feel that they need to. But this is kind of the situation that we're in.
Hi, my name's Annie Leblanc. It's not really a question, it's mostly a comment. I really, Terry's story really hit home with me. 4 years ago, I was diagnosed with bladder cancer, and I didn't really find that there was a lot of resources available for that specific type of cancer. I mean, we hear a lot about breast cancer, prostate, whatever, the most common ones. My doctor did give me information, which was mostly pamphlets from the States, so there wasn't really any local information, nothing Canadian. And for me, it was, you know, I was 38, single mom of 2 kids, just diagnosed with cancer, worst news ever. So I had a tumor removed from my bladder, and then was fine for a while, and then eventually it came back, and I had treatments, which the treatments for bladder cancer is a drug called BCG, which is basically, it's called a vaccine for tuberculosis. And a while back they were talking about shortages of the drug, and I kept thinking, what if we don't get the drug anymore? What am I going to do if I need it, right? So it's something that normal people really don't talk about or think about. It's a constant reminder every day. Am I going to have the drugs available? What if the cancer comes back? I've done treatments. So far, I'm good. But with cancer, we all know that you're never really foolproof. And I think Terry knows that. You know, you think you're good, and 6 months later, you're back. It's back somewhere else, or more aggressive than ever. So, you know, I second the recommendations that Terry provided to provide more resources to doctors so that they're more aware, they have more knowledge, that they can support us patients. even for me, there was no resources. I went to the Canadian Cancer Society, and they had no documents whatsoever. So I went home on the internet, and I Google everything, so that's what I did. And I found Bladder Cancer Canada. And I'm now a volunteer for the organization. I have been for 3 years. And I have their information. They have pamphlets. They have all the information you can have. I bring them to the urologist offices, to the clinics, at the hospital. For the past 2 years, I've organized an awareness walk here in Moncton. Last year was the first year here. It's September 23rd. And it is on the website. It is just to raise awareness and raise funds for research. We need more research done. We need to have drugs available, but maybe discover new drugs, new ways of treating it or curing it. And that's pretty much all I have to say. So thank you for your story, Terry.
Yeah, that's very good information, and you're doing great to do that. That's funny. You got to do it on your own. Like the doctors aren't saying, here's the organization in Canada that can help you. Like I had to do it on my own as well. Like no one gave me any information.
Yeah, and I think I'm a person like that when I want answers, I go for it, I search for it, because nobody else will do it for me. But a lot of people aren't like that, and they wait for their doctor to give them the information, right? A lot of people tell me, how do you do it, Annie? I said, well, I wasn't given a choice. I have 2 kids to raise. They're 11 and 7. I'm not going to lay down and cry, and I have to show them that Mom can do it and fight this. So.
Oh, that's great.
Thank you.
Yeah, very courageous. And there's a good one of the websites I use a lot of is clinicaltrials.org or .gov. It's .gov? .gov, which you can put any type of cancer or any type of disease in there, and you can see where all the trials are in the world, and you can even narrow it down to Canada and see where you can go. So that's one I use a lot of, and then I bring that information. Once I get it down to I should use that hand, 3 clinical trials that are in Canada, let's say, then I can go to my doctor and say, here's 3 that I'm very interested in. Can you contact them? Instead of going there with 50 sheets of paper and saying, here, can you spend about an hour on this? So you got to educate yourself too, like you're doing.
Carolyn, we do have one more question. Can we hold the question because we have 45 minutes at the end for an open question. I think we should probably move on. If you don't mind holding your question, we can do that at the end. We'll get to you first. Thank you. And I also had a live stream comment come in that I can also share at the end if we have time.
Thank you very much. Like Rose said, we'll have the opportunity to ask more questions at the end once we've gone through all the speakers, to allow everyone the opportunity to come up and share their stories. And so the next round of our speakers would be those that are our health policy influencers. Now, Stéphane Robichaud is not here tonight, but he has pulled together a video, and I will give you a quick introduction before we roll the video. So, Stéphane Robichaud is the CEO of New Brunswick Health Council. The Health Council has a dual mandate to engage citizens in the improvement of health services and to measure, monitor, and report on health system performance. Prior to joining the Health Council, Mr. Robichaud was Vice President, Planning and Operations with the Beauséjour Regional Health Authority. In addition to having led the implementation of the New Brunswick Health Council since its creation in 2008, Monsieur Robichaud has nearly 25 years of experience in the areas of organizational management and in public policy development, including economic development, fiscal policies, and labor force development. Now, before we roll the video, I want to point out, I think there are some slides in there, and if you want to get access to the information in the slides, you can access it through Facebook and Twitter, correct? So the slides that are going to be shown in the video will be available for you tomorrow. If you go onto Facebook or Twitter, you'll be able to access those slides.
Hello, everyone. My name is Stéphane Robichaud, and I'm the CEO of the New Brunswick Health Council. I'm sorry I can't be with you today, but I hope this short video will help provide some context for your deliberations today. Now, to help you appreciate or understand the content I'll be relaying to you, I'd like to first start by explaining the New Brunswick Health Council's mandate. The New Brunswick Health Council has a dual mandate of engaging citizens in health service quality improvement, but also of reporting publicly on the performance of the health system. From time to time, we're also required to make recommendations to the Minister of Health. At this point, I would like you to remember a very important learning from the early days of our work. Although legally we had all the tools required to access whatever info we needed, there was no standardized information pertaining to the health of the population, nor was there standardized information on health service quality to help guide decisions from a health service planning perspective provincially. So we've had decades of decisions, and this is still pretty much the situation today, that have not benefited from a strong understanding of health trends or health service quality situation. So at the Council early on, this spoke to the need for an approach, a framework, in order to identify the right types of indicators that would provide us the opportunity to do effective public reporting, but also can help us collectively better understand the population health and health service quality trend. Our first tool, framework that we developed, was in consultation with over 500 health system stakeholders. We adapted our population health framework, which was inspired by a Wisconsin model, Wisconsin, USA. Based essentially that programs and policies have an impact on health determinants, which can have an impact on health outcomes. This type of framework was very useful in identifying the types, guiding us in identifying indicators and organizing indicators, but also relayed an important message that when looking at the health of a population, health services only account for about 10% influence based on this model. 40% is associated to health behaviors, 40% socioeconomic factors, and 10% determinants of health. This framework proves very valuable in our work on indicators, and as our work progressed and our ability to identify indicators that would be accepted and could be used to compare parts of New Brunswick with each other, has led us to the development of a tool called My Community at a Glance, which you can access from our website at nbhc.ca, a wealth of information for each of the 33 communities in New Brunswick. A key learning at this point in our work was variability. What I mean by this is that as we measured various aspects of population health and health service quality, we came to realize that on many items, there could be quite a wide level of variability between communities in performance. So we could have very low performance in some communities, very high performance in others. Not one community being good at everything or poor at everything. It really depends on what we're measuring. So this really highlights the importance of understanding these different realities when approaching health services planning. From a prevention perspective, we know chronic health conditions are a very important reality in New Brunswick. In fact, New Brunswick is among the highest prevalencies in chronic conditions in Canada. So for these chronic conditions that are listed here, you can find out what's the prevalency of chronic condition in your community and how it compares to New Brunswick. Below here is the element of variability as examples. And as you can see, whether it's having at least one chronic condition, 3 or more, anxiety, high cholesterol, or having someone in their household with a memory problem that interferes with day-to-day function, you can have quite significant variability among all of our communities, and understanding the reality of each community is extremely important when looking at health services planning and health services delivery. Another example of this, and in this case, information used to help guide efforts on prevention to prevent heart disease and stroke, similar community-level indicators. And in this case, the two communities on the left-hand side at the top, Campbellton and Niguac, each have 6 areas where their performance is statistically significantly worse than the provincial average. This doesn't mean other parts of the province don't need to prioritize these areas, but this type of work can help people living in each of these communities appreciate where they could have the best bang for their buck as far as where the needs are most felt from risk factors perspective. So as you can see, 10 years later, this information is now organized in such a way it can really help us with these types of decisions. As a health system, we've known since 2010 now that our system is not comparing very favorably to other jurisdictions in Canada. This report card, when we're looking at letters like C's and D's and some A's, some B's, is on the premise that comparing the New Brunswick performance to other provinces and territories, the top performing province or territory getting an A and the worst an E, this shows where New Brunswick has fared. And primary health services, where we have D's pretty much all along the way here, speaks to an area in our health system where we really need to improve. It's proven to be a weak link in our system and requires a very strong focus moving forward. When looking at the poor performance of our system, many are quick to speak about the need for more spending, more human resources. And in fact, going into this election, we're likely going to hear quite a bit of that. But is that the main reason why we are having problems? When looking on spending, and here we have 2008 compared to 2016, and New Brunswick being in blue, Canada in red, we compare fairly favorably to national average when it comes to what we spend per person, and this spending has increased over time. So we compare favorably to provincial average, to national average, when we look at how much money we spend per person. Similarly, when looking at human resources, again, Canada being in red, New Brunswick in blue, we also compare quite favorably for most professions. We're either at national average or above national average. So, with this in mind, what this really speaks to is we should be getting better results, both from a population health and health service quality perspective, with the level of resources that we have. So, in conclusion, in your deliberation, I invite you to consider the next 3 points. That from a health system perspective, we really need to get better at identifying target populations by community so we can make sure that how we organize our services is the way that best meets the needs of our population. Secondly, we have to start to improve how our learnings in variability, in the differences of various health service quality outcomes in various communities, and work towards standardizing these outcomes. Regardless of where you live in New Brunswick, you should have equitable access to quality health services. And finally, we have to start focusing far more on improving the use of available resources. We will be spending more as a province on healthcare moving forward, there is no doubt about that. But we have to start using the resources we have far more effectively, far more efficiently. So, with this in mind, I wish you good deliberations and thank you for your time.
So unless you have laser vision, you probably didn't read everything on the screen there. So as I will repeat, if you want to find out, there's a lot of useful information in Stéphane's slides. You will be able to access that on Facebook and Twitter tomorrow. So I'd like to introduce or ask Linda to come back here, who's already been in the first panel. Linda has already shared her personal experience living with arthritis, and now she'll provide her perspective as the president of the Canadian Arthritis Patient Alliance.
Sorry you don't get much of a break from me. Well, I'll give a little bit of my perspective. I became president of the Canadian Arthritis Patient Alliance, I think about 5 years ago, but I was also one of the founding members back in 2002 when there wasn't really a lot of patient voice across the country. It was a new idea that patients would be engaged and consulted, and so we started the Canadian Arthritis Patient Alliance because we wanted to give patients that voice. We felt that there was a big piece missing, that the doctors could give so much, the government knew so much, and in my disease journey of the previous 15 years, I went through a lot of gaps in the system that I felt possibly could have been avoided if there had been patients talking at the table. So we struck the Canadian Arthritis Patient Alliance, and we began working with Canadian Agency for Drug and Technology and Health. We provide patient input into the drugs that they review when an arthritis drug comes up before them. I also am very involved with Health Canada, and on my bio mentioned the Expert Advisory Committee on Vigilance of Health Products. That was a number of years ago before the Conservatives were in power. This was John Chrétien, federal Liberal government, that had that committee looking at post-market safety of drugs and how we could improve that. So out of that committee, we saw things come like the MedEffect alerts that some of you might see in the MedEffect website that is trying to promote post-market surveillance and reporting of adverse drug reactions. So I was very involved in that committee. I also have been very involved with research networks. I was involved with the Canadian Arthritis Research Network, which was funded under the federal government's Network Center of Excellence. And they had a patient advisory committee to the network that advised that committee on all aspects of arthritis research, so all the projects that the network was funding. So we also been involved since then as a strategy for patient-oriented research, which came out a number of years ago, that was focusing, and I was so pleased to see finally New Brunswick as a partner on some research through the strategy for patient-oriented research in the Maritime Spore Support Unit. So it was very exciting now when I actually do grant reviews for the CIHR. I'm a patient reviewer, public reviewer for them. So when now I'm seeing New Brunswick institutions being reviewing grants that they've applied for, and it's pretty exciting to see the health services research that's happening now to try to promote and improve the healthcare system. It was a big piece that was missing because, again, no patients were talked about. Now we're bringing together researchers, we're bringing together patients, we're bringing together academics, we're bringing together government, all in the room talking about the different priorities for different diseases instead of, focusing just on what the researchers think should be done. So it was very exciting to see things progress over the last 15, 20 years that I've been a patient advocate, and I want to see that continue to improve and to see a continued dialogue between all the stakeholders that need to be engaged at the table, not just the physicians and not just the university professors and the different people, but I think we get far more done and far more accomplished when we all can get in the room together and we can talk about the issues and try to figure out how we're going to solve the health care issues, especially in a province like ours that's so small with not a lot of resources. So I think I'll leave it there, just give you a bit of where I've been involved in the last 20 years on the federal and provincial, not so much provincial scene, but the federal scene.
Thank you, Linda. Yes, you have to come back. We're bringing you back. So the third person in this panel, or the second person, would be Louise Binder. That's right. Louise is a lawyer and health advocate who has been involved in informing the development of health policy and systemic treatment access practices from a patient perspective for more than 20 years. She started her work in this area, in the area of the HIV community in the early 1990s, after her own diagnosis and before effective treatments were available for HIV. She co-founded the Canadian Treatment Action Council in 1996, which successfully ensured access to treatments and quality care for people living with HIV by working with the federal and provincial governments and other relevant stakeholders to enhance drug review and approval systems, pricing policies, and access to liver transplants for this community. She wrote a paper on universal drug coverage a decade ago while chair of the CTAC. 4 years ago, Louise began similar work in the cancer area and is presently a health policy consultant for the Save Your Skin Foundation. So, it's no surprise that she has been recognized by many organizations for her work. I'd like to introduce you, Louise.
Linda and I are about to need the same help with the microphone. I want to thank all of you for attending. I actually would like to take this there. I want to thank all of you for attending, the speakers, the political folks who were challenging with many, I think, interesting ideas this evening, but most of all to those of you from the public who came to talk about this issue and who, as a result, are really showing an active engagement with the democratic process, which, in my view, is really under attack in many parts of the world, some of them very close to home. And so I think that really it's wonderful that you're doing this. You're the most important part of this evening. I also want to thank you for letting me come across the border. Ontarians, I know, are not necessarily well received in Atlantic Canada, but I will do my best not to appear too upper Canadian in my discussions this evening, and you can decide. I do love lobster, but I know that's actually wacky because Atlantic Province people usually don't love lobster, but I can't resist nonetheless. So thanks so much for letting me be here. I have actually been working in the area of health policy for 25 years. I try not to think about that. But then the good news about that is I was supposed to be dead 23 years ago and decided against it. So I think that's the good side of the 25-year bit. The wrinkles, not so much. I do want to talk very much about what I think is a huge gap between what our health, quote, system, and I don't think we have a health system, which I will explain in a moment, what we have is a health system and what actually happens on the ground. And you've heard, actually, a lot of what really happens on the ground, which is very much different from what I think politicians and other powerful stakeholders would like us to believe. You're powerful. And I actually would like to say that I believe that politicians and the media are a large part of this knowledge gap that we have between what we say we have in Canada and what we really have. And as André pointed out, we hear them speak in sweeping terms about universality and sustainability and affordability and accessibility. But what do these terms really mean? And it's a question that I think you should ask every single time somebody uses the term. Oh, we promise you sustainability, or we promise you universality. Well, what does that mean? And I don't think we actually even know what the governments mean when they talk about universal health care. And what are they talking about when they're promising us now not just universal health care, but also universal pharmacare? I think we need to keep asking these questions, and I'm going to give you a few of my answers, and they might be different than some of the other stakeholders in the room. But not knowing the answer to the questions of these sorts doesn't mean that you're ill-informed or that you're not keeping up, but rather that anybody who doesn't know the big gap between what we are told we have and what we really have is someone who's never been involved on any long-term basis with the healthcare system. Because once you have, you can never unknow what you know. And I want to talk first about this universal healthcare system discussion. André mentioned, and there was a lot of talk about Europe. One of the big differences between European countries and Canada is this wacky division between responsibility for healthcare at the federal level and provincial level, whereas in Europe, they don't have that division. It's all a federal system. It's true that it's managed locally, but it's determined federally. And I actually think that's a huge, huge difference. So what does that mean? So we're told that all aspects of the system, including hospitals, doctors, and medications, are covered. That's what universal health care should be. And it's for everyone and equally across the country. And I'm here to say what you probably already know, that is about as untrue as the existence of the truth fairy. And we don't have that. We've never had that. One of my jokes about this, I think it's meant to be a joke, is that if the Fathers of Confederation had been the Mothers of Confederation, they would have included drugs in the Canada Health Act instead of just doctors and hospitals. And I suspect that the provinces are actually, and you can comment on this or not if you wish, sorry that they didn't insist on drugs being put in. And the story is that the federal government offered up drugs on that list, and the provinces said, no, we don't need that. So I guess hindsight's 20/20. Yeah, we can talk about that later, but that's the story. So so we really don't have, first of all, we don't even really have universal access to doctors and hospitals, even though the Canada Health Act says we do. We have some access to some doctors, some of the times, maybe 18 months later, and we have some access to some hospitals, some of the time, maybe waiting in emergency for 2 or 3 days, and actually some people dying in emergency waiting to be seen. So if that's universality, it's not quite my definition, so you might want to ask about that. But we certainly don't have all, even in hospitals and even with doctors, we certainly don't have everything covered that they do for us and that we need doing. And I'm not talking about luxuries, but filling out forms for long-term disability, or in my sister's case, breaking a leg and being told that she could have a plaster cast that would keep her unable to move or work or do anything for 6 months, or a plastic cast that she could pay $300 for. So that's not my idea of universality either. But the worst part, of course, is around treatments, medications, and drugs, because those are solely within the jurisdiction of the provinces and the territories. And I'm actually very sympathetic to the provinces, because we know that each province has a different economic engine, depending on resources and a lot of industry and all kinds of other things. And so it isn't really realistic to think that they can afford the same amount for a health budget. I actually think that most of us, patients, understand that. But that doesn't mean that we can't do the very best that we can with the resources we have. And it also doesn't mean that we couldn't work better together interprovincially to have better systems than we do. So please understand that we understand. We're not asking for everything. But one thing that I've come to believe in very much is something that's called value-based health care. And you've all talked about it tonight, although you didn't necessarily use those words. But what that talks about, and I would like to recommend that politicians think about this, even though it will upset many, many of the powers that be, and that's removing the silos in the health budget. So in other words, take down, don't say 16% of our budget will be drugs and not a penny more. X% will be in hospitals and not a penny more. X% will go to doctors and not a penny more. That's not good health care policy. Good health care policy is, as Stéphane mentioned, looking at populations of patients, deciding what are good health outcomes for that population, and then working as a team of doctors and other professionals to decide where money needs to be spent for that population to get that outcome. And if every penny of it needs to be spent on physiotherapy and medications, then that's where you spend it. If it needs to be spent in psychiatry, that's where you spend it. You put the money where the outcomes will happen. Right now, a doctor, and I don't have anything against doctors, some of them actually helped me stay alive once I told them how to do it. So, you know, I've got nothing against them, but right now, when you walk into a doctor's office, whatever happens coming out of that office, they get paid. Whether they said, nice to see you. I once had my doctor, I went in, I said, I'm having terrible back pain. She says, me too, I think it's the weather. And then I wasn't sure which of us should be like sending in a bill to our insurance system. Was it me or was it her? I was a little confused that day. But you know, really, it's not about outputs, it's about outcomes. So if we just did that, I promise you, and you can drag me back from Ontario and put me in a public square if it's not true, I promise you, you'd get better efficiencies, you get better health outcomes, you get people at work. Of course, your doctors won't like that, your hospitals won't like that, because it really will mean moving things out into the community, but that's really where the action is. And patient engagement will tell you that. We don't want to sit in your emergency rooms. We don't want to sit in your doctor's offices. We couldn't. It's the last thing we want to do with our time. We can tell you, I sincerely believe we can tell you how to be much more efficient and effective and save money at the same time. So I believe in that. Don't take me wrong, I'm not suggesting that there's any villains in this piece. It is a systems problem, but we don't have a system. I've heard over and over tonight, and I was in the same situation. The only reason I'm alive today, and I believe the only reason everybody else who's spoken here is alive and well and here to be with us tonight, is because they took control of the situation. I took control. I also went to the United States before there were treatments in Canada and talked to the researchers there. I also, and André, I think, covered some of those stories, ranted and raved and, you know, laid down in the streets and did all the things we had to do to take control. But that's not a system. That's just a process. And if you're lucky enough to know how to manage that process, you'll get what you need. We've heard from everyone. I did the research. I told my doctor do this. I asked my doctor do that. That's not how a system works. And we really need to move away from that. That's great for people like us who have resources, who are privileged. But most people are not. And so they shouldn't have to ask, am I entitled to this? The system should say, you're entitled to this. And we don't have that. We don't have it anywhere, but certainly including New Brunswick. And we need to turn this ship around to a value-based system. So I want to say a few specific things about New Brunswick. I want to talk first about drug coverage. So I noticed, and I've done my research, that the health spending in this province is lagging behind GDP. And as André pointed out earlier, you know, spending is in the eye of the beholder. And if you're really getting value for that money, spend it. So I think you should think about that. One of the other things, and I'm going to come back to this, and you talked about pharmacare. I'm promising you I'm going to give you a short story on pharmacare, the Louise Binder short story on pharmacare in a minute. But keep this in mind because it's very important to that story. New Brunswick spends $312 million in public prescribed drugs. And you spend, listen to this, $759 million on private prescribed drugs. Hold that thought. You're the fourth lowest in spending for public care, and most of the other provinces are Atlantic, and so we understand the economic engine issues there. But just hold that thought when you're thinking, when we come back to pharmacare, because imagine if that private coverage wasn't there. And that's a potential under pharmacare. So I'll come back to that, I promise. But think about it. And certainly I would suggest that with drug coverage, you're going to have to remove the deductibles. If you did nothing more than remove the deductibles and the co-pays for people who couldn't afford it, you would improve the health in this province profoundly. And you get people back to work. It would be good for the economy. But of course, as long as we silo budgets, nobody cares. Nobody cares about what it does to industry. Nobody cares what it does in the workplace, because all I care about is my little slice of the healthcare budget. Dental coverage. You mentioned dental coverage. Absolutely, there should be at least a minimum dental coverage for everybody. I still remember reading a story in the newspaper in Toronto that it really broke my heart, of a man who was very poor and couldn't get dental work done. He died of septicemia, and it was because of rotten teeth. That should never happen anywhere. Now, that said, I would like to upset the dentists in the room, if there are any. You charge way too much, and you should be regulated just like doctors. So there are ways to deal with that problem too. I actually think veterinarians too, but that's perhaps for another story and another night. Home care. The federal government gave the provinces money for home care. Not enough, by the way. And I'd be glad to go and visit them with you and tell them that story if you like. Not enough, but at least let's make sure that we use that money to keep as many people at home as we can. They also gave you a pittance for mental health. There's no question that we're completely overburdened the burden of disease relative to the amount we have for mental health spending is just not enough, nowhere near enough. But I sincerely believe that if you work with patients, they will help you understand how to do things effectively and efficiently in this area, as in all, and that really we can do better with the mental health spending that we've got. Hospital care. I can tell you how to save some money in hospitals. I bet you're paying way too much for people at the top of those hospitals, and you could save a ton if you got rid of them. One of the only things that our new government did that I liked was get rid of the head of Ontario Hydro, who was making $6 million plus bonuses a year. And my hydro bills just kept going up, and they're unreadable. You would have to be a forensic accountant to even know what they were charging you for. And I have a suspicion that we could do a little better at the top of the hospital system. Not meaning anybody in particular, nothing personal, but we pay so much for the high price help in those places when really it's the other folks doing an awful lot of the heavy lifting. Daycare. Nobody's talked about daycare, but we have talked about social determinants of health. And to me, if we don't do something about daycare, we can't get people into the workforce, and we've got to find a way for some basic daycare for people. And last but not least, I want to come back to pharmacare. Pharmacare could be great for New Brunswick, and it could be a nightmare for New Brunswick, and it depends on how it's structured. In Ontario, we got a slight taste of pharmacare when they brought in something called OHIP Plus. And Dr. Hoskins is the same just keep this in mind, he's running the National Pharmacare business, and he ran OHIP Plus. I have high regard for him, but there were a few little glitches on that one. The biggest glitch was that the government decided that it would become the payer of first resort even if people had private insurance. So think about that in a province like yours, where twice the spending for drugs is through private insurance. What happened in Ontario was that all the private insurers said, we're not paying for your kids' drugs. This was a plan for kids up to 25. We're not going to pay for your kids' drugs. Even if it's the drug is listed on your private plan, you got to go to the province first. Okay, so people, first of all, it meant these kids had to wait. They went to the province, which takes much, much longer to make a decision than the private plans do. Mostly they were turned down. They went back to the private plans and said, okay, now we've been turned down. They said, no, not yet. Go back to the province and ask under their compassionate access program if they'll give you the drugs. So we bogged down our compassionate access program for people who really needed it. And we had a bunch of people who really already had coverage if we just let them use it. And then they got turned down. And then finally, months and months and months later, and millions of dollars later, they might get it. So if they don't buy this, and I suggest it to with all due respect to my provincial colleagues, if they offer you a plan where you're the payers of first resort, say, not so fast. The other thing I think would be very bad for everywhere, except maybe not in New Brunswick, you'll have to decide, is there's talk of lists. We'll have a list of drugs. You know, that's a problem because not everybody needs the same things. And you don't want to be in a situation where you really need something and you can't get it. I don't entirely know the answer to the list problem, but you need to think about it if they're offering you a list. So it could be good if they would offer you some, to me, what would be great, in my opinion, for New Brunswick, and you tell me if you agree, and I don't mind if you don't, but to me, if the government gave you some funding and the government used it to fill the real gaps in drug coverage for people in this province, people who have no coverage at all, or people who can't afford to even get in the system because of deductibles and copays and traveling outside the country and so on, if they just did that, I sincerely believe that would be great pharmacare for this province. You might think something different, but that's my 15 cents on it. So just watch the fine print, because they keep the two things they say they're going to give you. They're going to fill the gaps. How are they going to do that? The gaps are different in every province, so how are they going to do that? And the other thing they say is there'll be universal coverage. Okay, you can have, universal means the same. The same can be the same really bad stuff, no innovative drugs, a small list, or it can be the same and really the best we can have. So, you know, read the fine print, which I think a lot of Canadians haven't been doing on this pharmacare stuff. I'm for pharmacare, totally, but I'm not for crummy pharmacare. I'm for pharmacare that really makes a difference for people. So I'm sure I'm way, way over my time. But the only last thing I want to say is that my organization and a number of other organizations, including Linda's, and a number of national organizations, do a lot of work across the country. And if any of you are interested in working with us, and we work, of course, provincially as well, so anything we can do, and anything you can do with us, we'd be very happy to have you join us. I think we're stronger together, always, not only across the country, but across disability groups. If it's good for one, it helps all. So please join us, and please vote. Vote early, vote often.
Thank you, Louise.
Well, I think we're happy that you crossed the border. You have a lot of passion, and we can feel it. So thank you very much. And you're right, it is good to share our experiences within provinces and pull out the good tips that come out of it. So now we'll take a few minutes to answer some questions. Maybe maybe a couple minutes because we are a little bit behind time. Or if you want to wait till the last period.
Yeah, why don't we, unless somebody has like a burning question right now, we can take it. Otherwise, we can allow our colleagues to respond to all the exciting ideas that have been presented for their consideration this evening, and then we could just open it up to the gang. Is that good? Okay.
All right. Well, last and certainly not least, we have our last panel. With our politicians. And I'd also like to note we do have, I've been told, we do have a PC rep in the room, but not as a speaker. And so the first person I'd like to introduce you is our Minister of Health, Benoit Bourque. Benoit was elected for the Legislative Assembly in the provincial election 4 years ago as a member for Kent South. He was appointed Minister of Health in September 2017. He was also appointed Minister responsible for Service New Brunswick in May 2018. He served as Chair of the Select Committee on Cannabis, Vice Chair of the Standing Committee on Estimates and Fiscal Policy, and was a member of several standing committees. Monsieur Bourque lives in Bouctouche, New Brunswick, where he has a strong record of community service. Join me in welcoming Benoit.
I think it's easier for me to do that. Merci beaucoup, Caroline. Bienvenue à tout le monde. Si vous avez des interventions en français, n'hésitez pas. Thank you, everyone. It's a pleasure for me to be here, and I found the last couple of hours and a half very, very interesting, in fact. And I'm happy to say that had I heard this presentation even a year ago, deer headlights come to mind. It's funny how 11 months now as a Minister of Health, I actually understood what you guys were saying, and that in itself is kind of reassuring. I also want to thank the presentation of Monsieur Picard because, to be honest, I felt that he raised exactly what a Minister of Health needs to consider day in and day out. Considering the costs, considering the value, considering, how can we best use the money that we have because it is in limited supply. Yes, the healthcare is approximately 40% of the total spending of this province, of the government of New Brunswick. Yes, I am eating a lot of other people's lunch. As Mr. Picard said, and it's difficult because, and just sharing my story as an MLA, and I'm sure Mr. Kuhn can share the exact same thing. I've had, especially since I've been Minister of Health, we're talking about, what I'm realizing, and I'm not, the last thing I want to do is offend anyone here. But we call the Department of Health one of the social departments, along with social development. Why? Because we are dealing with people in a vulnerable state, okay? People in a vulnerable state. And when we are in a vulnerable state, I'll be blunt here, sometimes it kind of puts, we kind of see often the worst in people. But oftentimes, the good news is we see the best in people too, because that's where, and sometimes it's a roller coaster. But what I guess I want to come at is the fact that it's very, very emotional. Okay? So when we are dealing with healthcare, people in vulnerable states, which many of you are, and I appreciate the testimonials that you gave, and I want to thank you for that, and thank you for your courage, is also the fact that it's tough when you have to measure value to deal with somebody who is very emotional and in a vulnerable state. And I've had in my office people crying, saying the government is not helping me because I do not fit in this program. Help me. I need help. I can't pay my bills. And I'm sure, Mr. Kuhn, you've had the exact same thing. This is the reality, and I can say that it has increased exponentially since I've been appointed Minister of Health. And one of the toughest things that we have to do is sometimes we have to say no, like Monsieur Picard said. And it's not because I love saying no, trust me. It's the last thing I want to say, especially as a politician, because we're in the vote-getting business. And the vote-getting business is trying to please everybody as much as you can. So I don't want to say no. But at the same time, you know, beauty is in the eye of the beholder. But sometimes when somebody is in a vulnerable state, value is in the eye of the beholder as well. So it's tough to measure value when you are in that state. And when you are advocating for your, you know, for you, that has a lot of value. If I go to the Tim Hortons in Bucktouche and talk about other things, some people will say, yeah, it's important. Someone's going to say, well, no, because I have somebody in my family with another condition, and that is more important. So those are the struggles I have to deal with on a daily basis as the Minister of Health. So, sorry, I don't want to sound bleak, but it's very difficult to be the Minister of Health. I guess that's what I'm coming at. So I actually came prepared with a list, and literally a list of things that we have done as a government in the past 4 years now. Now, I think I'm not going to go through that list because, you know, I think it's more than lists. But what I can say is that, in broad terms, we have decided as a government, as the current government, that healthcare is a priority to New Brunswickers. We have not cut into healthcare. We have actually invested more. I believe it's around 3% annually that we have invested to the healthcare system here in New Brunswick, which is pretty much in phase with the inflation rate. I think it's actually a bit higher, but I need to verify that. But I know, and actually, my deputy minister was actually saying, he said, you know what, since he's been the deputy minister just before we became government. And he said, I'm happy to report, because he talks to all the other deputy ministers, and he says, we've been left alone. You know, we haven't been asked to cut anything, and I know that's not the case for many of the other departments. So I can say that, and I say that kind of proudly as a government. We have invested a lot in healthcare, hence the long list that I have. But I guess the other, and one of the things I am happy to report is mental health. And we've talked a lot about mental health. For your information, my mother is a retired mental health nurse, which she did for about 20 years. I like to joke that she was working 24 hours a day. If not at work, she was working at home. But it is something very near and dear to my heart. And I truly, truly believe that mental health, did you know that now in public schools, now the number one issue in public schools right now is mental health. And that is only since a couple of years. Before that, it was something else. You know, dropout rates, or now it's mental health. So, you know what? Mental health is, I believe, one of the major areas of development that we will see in our healthcare system in the coming years. I see it, if not the most important, definitely one of the most important ones. I'm happy to report that we have, I think my executive director of the mental health services was saying that we basically, like in the past 4 years, we tripled we basically tripled the amount of money we put in mental health. That sounds like a lot, but we didn't start with a lot. So, you know, it's still highly, highly insufficient. But I'm happy to report that we've, you know, I think we're moving in the right direction. And I can certainly say, and maybe to answer the question that was asked earlier, if our government would commit to more mental health care investments, the answer is definitely yes. I can say that the Liberals would definitely do that. It is important. I think it's showing that it is near and dear to my heart. There's a lot of things that resonated, and I can maybe address that quickly, about the clinical trials here in New Brunswick. I know that that is on our radar. It's actually highly on our radar. And this new cancer building that's being built here in Moncton, we're banking on that. I was actually talking to the director a couple of days ago, and that's one of the things that's high on our priorities, to get more clinical trials here in the province. So I'm hoping that'll see the day, and we'll see more of that. It resonated a lot about all this patient engagement that many of you touched upon. I think it's really, really good. I think you're right. It cannot always be about the people giving the care. It needs to be about people getting the care as well. So how can we do a better job in that? And you're right, it's not always about spending. It has to do with how can we better direct the resource that we have. If you ask me what keeps me up at night regarding healthcare, it's the fact that we are the oldest province in the country in terms of age. We are. There's statistically proven. With more age comes more chronic diseases. Thank you. Jeez. Sorry, my French kicks in sometimes and I get blockages. So yeah, more chronic diseases, more of a strain on the system, and of course it's all important. It's all important because we care about sometimes our health, but oftentimes the people that we love. And that is what we need to do. So how can we be sustainable? That is the big question, and we are looking always on how we can better improve our healthcare system. Now, I know I've been very, very broad. I mean, this is a topic we could speak about for hours and hours on end. I think I'm going to leave it there because I don't like taking my allotted time. So thank you so much, and I'll be happy to answer any questions afterwards.
Thank you very much. And I can see you do have a few things that keep you busy in your job. A lot of demands. Our last person, but not least, is David Kuhn, the leader for the Green Party. David was elected to the Legislative Assembly of New Brunswick 4 years ago to represent the people of Fredericton South. He became the first elected Green MLA in New Brunswick history and the third Green parliamentarian elected in Canada. Mr. Kuhn has served as a leader of the Green Party of New Brunswick since winning the leadership of his party in 2012. Mr. Kuhn is a member of the standing committees on public accounts, Crown corporations, and economic policy. He is also a member of the Legislative Administration Committee and served as a member of the Select Committee on Climate Change. Come on up.
Well, good evening, everyone. Ça me fait plaisir d'être ici avec vous ce soir. It's great to be here. I want to thank Carolyn and Rose for organizing this forum, this town hall. And all Rose, Carolyn says, yeah. Thank you to Linda and Louise for your comments on policy. It was very interesting and helpful, I found. And as well to Linda and Jacinthe and Terry and Annie for sharing their personal stories. That's not an easy thing to do, and I think everyone here appreciated your courage in doing so. So the minister and I have a couple of things in common. We're both the class of 2014. We were both elected in 2014. Both of our mothers are nurses. So we have this thing about being sons of nurses, that's a whole other thing. We won't get into that. But yeah, it doesn't, it stays with you for life, let's say. And the nurses in the room know why, probably. We also are the only two MLAs who sang on the record from our seats in this last sitting. It's true. So I like to imagine Hansard reporting that the Minister of Health sang, in brackets, beautifully, which is true. He has a beautiful voice. And the leader of the third party, which is what I am and how I'm referred to there, in bracket, sang, in brackets, terribly. So I will not sing again, should I be reelected, but Minister Bourque, I'm sure everyone would enjoy hearing him again, honestly, an impressive talent. So we're here to talk about health care, and right off the bat, you look at the term health care, well, it's about care. And one of the things I felt in New Brunswick over a number of governments is whichever of the two parties who have been in power is we've tended to increasingly lose sight of the care part of this, and the effort has been more and more to try and run healthcare like a business. And so that's failing on the care side of things. And we now are in a situation where we have so many people in the system who are burning out. It's getting more difficult to recruit, whether you're talking about nurses in our ERs or paramedics in our ambulance system, or people working in our senior care system in the nursing homes. So we've got to get back, I think, to the notion of care. I mean, we've got to the point where the system now is squeezing the compassion that everyone came into the healthcare system with, squeezing that out and making it that much more difficult for them to care in the way they want to. So we need, in a sense, system change. Now, we do have we have quite an unhealthy population, which is one of the things driving our healthcare costs. So why? Well, one of the things we're facing in New Brunswick is significant levels of poverty. They haven't budged in many, many years. So this is kind of the longer term part of this. If we're going to tackle healthcare in a significant way and bring about a healthier population, we need to tackle poverty head on. And in my opinion, that means we've got to put in place a basic income guarantee in New Brunswick, so that people will have sufficient funds to live on, and more will have the ability to escape poverty. Right now, it's quite a trap. Saskatchewan was the first province to introduce Medicare, and then eventually became a national program. Why couldn't we in New Brunswick become the first province to introduce a basic income guarantee with our federal partners? Is the only way it could happen. And then it could spread across the country. It would make a huge difference in New Brunswick, and it would make a huge difference in terms of the overall health of our people in this province. So that's something that I think is critical that we look at doing. Also, sort of big picture, we look at the other social determinants. I want to just highlight a couple. One is addictions, alcohol and drug addictions. We don't have, and we need, a harm reduction strategy around alcohol in this province. We have significant problems. It has become normalized. I mean, the addictions, the dependence disorders with alcohol have become normalized so much that because it affects so many families. Everyone has had some experience with a member of their family, close or more distant, or a friend who has struggled with alcoholism. We need to address this. We need a harm reduction strategy, and we've got to do it. And that will make a difference. The health costs associated with alcoholism in particular in New Brunswick are significant. The Department of Health has done an excellent piece of work looking at this. The numbers are all there. It's good evidence for the minister to work from, and so we need to get that work done. We also need to focus on young people, of course, both in terms of diet and physical activity. So we can do a lot of good in the schools, both with diet and with physical education. And we can do a lot of good, I think, in trying to work in the food system to remove some of the temptations around poor food for our children and youth. And the federal government is working on eliminating advertising directed at youth, which will be important. If they end up not being able to do it, we should do it. Quebec has done it. We should do it. So these are big and longer-term efforts that we should undertake with longer-term impacts. One of the challenges here, of course, is this requires investments in areas that don't see, in departments that don't see the direct benefits. The benefits go to health. And we're asking social development, for example, to shift the way they're spending their money. And that's a problem. It was mentioned earlier with I think Louise was talking about it in particular, the way we're siloing budgets and siloing our thinking, and we've got to get past that. Now, in the shorter term, there are many things we can do. You know, it's interesting. When I first became an MLA, and you know, there are a lot of people coming in and continue to come in looking for help with various things, and many people living in poverty, in fact, make up the lion's share of those folks looking for assistance. And I remember saying to some whose problems were just so difficult that I wish I had a wand like Harry Potter that I could haul out of my suit and wave to fix the problem. Sometimes you can help, and that's very satisfying. I don't think there's a member of the legislature of the Parliament of Canada who doesn't look back and feel like they've made a difference in some people's lives in their work at the constituency level. But sometimes you can't. So the same thing, I think, is true for the larger issues around health right now. You want to be able to pull a wand out like Harry Potter, and there's a great spell he has, which is expecto patronum. Expecto patronum, if you're a Harry Potter fan, which basically is to call up the Patronus, which are sort of the spirit animals, badass ones, to drive the dementors away. So we've got dementors sort of operating in the health system here, which is leading to poor outcomes for people. But in the short term, there are things we can do with fairly quick results. One is we can stream nurse practitioners into the system. We can stream nurse practitioners into the system. We can bring them on payroll. We can arrange through Medicare so they can start to perhaps start their own practices. Whatever the particular solution is, we need more nurse practitioners in the system, and that can be done pretty quick. We need everyone working to their full scope of practice. So, for example, pharmacists. We have good legislation in terms of the scope of practice. They can do a lot, but it's not covered. It needs to be covered, and it would save us so much money. There's been a great study that looks at what pharmacists have been able to do with urinary tract infections across Canada, where pharmacists that is covered. Tremendous results compared to what physicians are doing. Pretty impressive. So we need to make sure that can happen. The same thing we can think of, many practitioners in a healthcare system who could be doing far much more if the system was set up to welcome them and incorporate them, so everything wasn't kind of orbiting around physicians. I think of midwives. We have a few midwives now in the province, but we should have them across the province. It would take so much pressure off our OBGYNs, who can focus then on the high-risk pregnancies, which seem to be increasing in frequency, and provide the kind of prenatal and postnatal care that midwives are so capable of doing, which will have many other benefits down the road. The same with optometrists. So it's that kind of thinking I think we need in terms of rapid short-term change to create a more integrated, collaborative system, which I'm sure is easier said than done. The Minister, I'm sure, can attest to that, because we have a big system, and they're hard to change, but we do need to change the system. We do need to transform it so it in the end is working for people. that it is all about care, and that we get much better outcomes for people, because right now that's not happening. And one of the things I'm most passionate about is the lack of access and poor access to mental health care in this province, particularly given the tremendous upswing in anxiety and depression disorders among our youth and children, is reaching a pitch now that is very worrisome, and we need to come to grips with that and provide more rapid and effective treatment for our youth and children now. And I've talked to GPs who are throwing their arms up saying, I don't know where to refer them because the waiting times are such and such and they need help right now. And talk to school administrators and they're saying, we don't know what to do with these kids. So it's something we've got to grapple with, and we've got to grapple with it immediately. And so that does speak to where we place our priorities. We do need to effectively argue on the national stage, I believe, to return the Canada Health Transfer system back to the way it was, where there were adjustments made for rates of poverty and for demographics in the provinces across this country. There's no reason that shouldn't be there. That's really, part and parcel of what we're about as Canadians. Those provinces with special needs should get that extra help, and we need to do that. But that requires premiers pulling together, and that's not easy, but we need to do that. So those are just some issues I wanted to highlight. I'm very much, and we're very much focused on the need to see decision-making about healthcare being community-driven. That was mentioned earlier by Stéphane, I think, in particular, to focus on particular populations, engaging particular communities, so that decision-making is getting driven more from a community perspective rather than from 30,000 feet, where we have such significant hyper-centralization of the system now. I think it's just gone too far in terms of centralization. We need to start to decentralize back so decisions are getting made at a local level to address local needs in an effective, meaningful, and ultimately cost-effective way. Thanks very much.
Thank you very much, Mr. Kuhn. I know that you too have a lot, and you shared a lot of your thoughts, and perhaps it's answered some of the questions for some of you in the group. If we had time, we'd get a duet started right now, but we don't have time, unfortunately. We have about 10 minutes, I believe, and so I believe this lady here, we had promised her, was this, this lady here had been promised.
Yes, you had a question earlier.
A question?
Yeah. Before I get to the question, I just want to thank MLA David Kuhn for having decided to meet with me out of all the parties, and we met at downtown and a couple of months ago. So I appreciated what you had to say. One was a comment to Terry, and two of my siblings passed away from brain cancer, one in 2005 and one in 2008. And I think they probably saw the same doctor you first saw. And unfortunately, I wish you all the best, because it does. My other question was for Jacinthe. And again, thanking you for sharing your story. As a caregiver, you have given me hope. You said, Jacinthe, that one of the keys to your recovery was attending CMHA support group. And I don't know if you work with CMHA or if there's under CMHA here, whether there's these not programs, but groups rather than programs, whether these groups ongoing or still ongoing. Because I've heard that they're not.
I volunteered with the organization for a long time and participated in the groups, but in Moncton there's definitely some groups that are continuing, and You could definitely talk with Kristen. She would probably have more information.
CMHA has moved towards a multi-service delivery model. So while we are offering some closed groups now, which are a set number of sessions, we are also still offering ongoing sessions as well, related to different matters. So we have a wellness-oriented one, which is ongoing, and we also have a family and friends one, which is ongoing as well. And in addition to that, we've also recently launched our walk-in service for individuals, which is an ongoing basis. On that same token, based on client feedback, we also have introduced some closed-based programs which have proven to be really impactful and effective, working with different clinicians related to some of the needs that clients have served. So it is, I guess, a dual model in that way. And we have also been implementing some peer co-facilitation with those as well. So we have multi-components to the programming. Of course.
Excellent. Is that helpful? My concern is wait times for surgery, and I'm specifying hip surgery, knee surgery. And for example, my husband, is going to be 2 years in August that he's waiting for a hip surgery. Obviously, his quality of life is not good. He's basically an invalid. It trickles down to my quality of life, and we're not the only ones out there. And I don't know why, but I mean, 2 years is too long. It has to be looked at. I mean, because, and like, okay, we're an aging population, but if seniors have to wait 2 years, and hopefully he's not going to have to wait 3 years, it leads to other complications. So we're pointing the finger at seniors. I get offended a little bit with that, but and if we have to wait 3 years, 2 years, well, we can point the finger at the system, say there's something wrong somewhere. I don't know where, but definitely something wrong. And just for example, I know there's the access management there where you can call to know where you're at on the list between. So he called 2 months ago. It took 4 days before he got an answer back. So he decided to call again last week. He called all week. So finally today he got someone on the phone to basically tell him, well, you're on the waiting list, but I'm not sure if it's going to be September. Well, we know you're on the waiting list. It's not new. It's just that, and we're not the only ones. I mean, I talk to people out there, and I mean, so the longer that senior's going to have to wait is going to cost the system eventually, because then it leads to other complications. So anyway, that's my view.
Yeah. Well, I'd like to comment on that quickly. No, I'd appreciate that, and you're right. In terms of wait time, and specifically for hip and knee replacements, there is a specific bottleneck situation here in the Moncton area, which is specific to the Moncton area. We have invested more money here in Moncton specifically to increase the hours of operation in this past year. So things are moving a bit faster than they were. However, it won't go from 2 years to 2 months. Let's be honest, but it should help at least somewhat. Also, specifically, if we look at, now I'm going into the weeds here, but Georges Dumont is going to open a new operating block with 10 operating rooms, additional one, but that it will be in 2020. They're building it now. It's that gray extension that they're building close to where the Vanier School was. So that's being so in 2 years, that should be alleviated a lot. But that is, so we are aware of all of that, but sometimes the solution cannot just be dealt with, within it takes a while. And I don't want to offend anybody when I talk about seniors, and again, No, and I understand because I understand you. You're going to be 50 years old very soon, and I get that. But no. All right. Come work for me in my writing. But in all seriousness, though, it does put. And I don't want to say that because I have a mother who's 75 years old. My father's passed away. We all have all our personal stories about healthcare, and we don't want to see. But the reality is, the baby boomers are getting older, and we are the oldest province, and it's putting a strain. And not because people want to. It's just the probability and just the way it works, and it's not personal. My God. Of course, you can't be a productive member of society, and there's a whole lot of consequences, and I agree.
Has there been any move to adopting a centralized booking where it goes through one single booking for the province, so that if St. John's wait time is 2 months, that somebody could opt to go there?
Okay, I'll just repeat the question for the live stream. If there's been any type of centralized booking system that's been thought of for these types of operations in the province, the answer to that is I'm not aware of that. It hasn't, to be bluntly honest, it hasn't come across my table. Okay, well that's that. I appreciate that. I'll bring that forward, and thank you for bringing that up. I'll look into it. Thank you.
I'm going to have to, because it's a few minutes before 9, I'm going to allow one more question for this lady over here. Can I?
So here they are. Please read them. And I'm going to follow up with you. Should you be reelected and should you become health minister again, I'll be following up with you, okay? Please.
Thank you. This gentleman here has. I think you had a question, and then this will be the last question.
This question concerns the specific topic of suicide. Now, Brunswick is one of the highest rates of suicide in Canada. Okay, most suicide statistics are very inaccurate, and they don't include attempts or whatever. New Brunswick has the CHEMO helpline. Okay. It's listed in the International Directory for Suicide Prevention Hotlines. Okay? To my knowledge, CHEMO does not have any professionally trained, certified suicide depression counselors or therapists or psychologists. They don't have. They have, there's another term that's used, I'm just not going to use it here. They have some basic training, but they are not professionally depression counselors, suicide counselors. They have some basic training, as I just said. And their main thing, what they do, is they evaluate to make a suggestion as to what service to access. 2 alternatives. Mobile crisis team in their area, and the other is the hospital emergency. To my knowledge, neither service has any trained professionally certified suicide counselors or therapists when they're in that crisis, they're in that situation, okay? The mobile crisis team, their only alternative is to take the person to the hospital with the police, okay? They have no say in whether the person gets any help. The hospital makes that decision, okay? To admit the person to the hospital, okay? If they're not admitted to the hospital, that happens quite a bit, they are not connected to any actual help, okay? If they are admitted to the hospital, even when they get to the emergency, there's no one, as I said, no one at emergency to deal with a counselor. No counselors, okay? I'm going a bit backwards, But if they do get admitted to the hospital, and this is all to my knowledge, some of it's personal knowledge, and some is based on other parents or persons that have actually gone through it, okay? When they get to if they get to the hospital, they do not receive any professional suicide counseling on the unit. They don't get it. Okay, they don't have them. They don't get the help, at least from what people have told us, okay? When they're discharged from the hospital, they're not directed to continue to see a psychologist or referred to one. They're just to a professional trainer. Because to my knowledge, I don't know where there is one. The community mental health center may have psychologists, but I've no one's ever said to send them there.
Can I assume?
My question is simple. Are you committed to hiring of any professional, trained, certified, suicide, depression counselor, therapist, psychologist to address this problem in the system, perhaps starting with chemo?
Well, thank you for that. I appreciate the question. I would say this. You are correct in saying that suicide and suicide prevention is very, very important. Yes, we need better resources to tackle the issue. What I can commit to, the solutions that you are suggesting may be the right ones. There may be other solutions that can help with that. I need to verify the whole spectrum here, but I can commit to say that we can do better, and we will look into how we do better. How are we going to do that? It could be with the things you suggested. It can also be through other means. But you're right, and I know that we will, and this is part of the mental health services, I would say, umbrella. We definitely will invest more in that, and that includes suicide prevention. I know I've been personally having discussions with First Nations, and in First Nations it's a highly prevalent, and not just First Nations obviously, but yes, I can commit. I can't say how, but I can commit that we will. David, do you want to add something?
Well, I mean, the other flip side of this is that we have a tremendous problem with accessing psychiatrists and mental health care overall. And so, we need to solve that problem. And we've got, there's psychiatrists who are willing to move and locate, but we also have regional problems where we have, the Medicare billing number caps will not allow us to hire more psychiatrists, like in the Fredericton region. And that's a problem because we're short, and we need to be able to have that removed to hire more. So that's the care that should come in terms of what I said earlier about kids and youth with anxiety and depression. The access to care in a timely manner of high quality is just not there, and it needs to be there. So you minimize even getting to the point of the rate of suicide attempts and suicides we've got in New Brunswick.
Thank you. I will be brief here because we are past 9 o'clock. I just want to thank you all, first of all, for attending. Someone mentioned, and it came up a couple times, where people taking control, staying home and doing nothing makes no difference. Being here tonight, sharing your experiences, your questions, your point of views, that's where change starts to happen. So I do want to thank everyone who's joined us through live stream, who have joined us here in person, our speakers and our hosts, and so I do want to remind you that we will not be following up on unanswered questions, but you are welcome to spend a few more minutes in the hallway because I think we have to vacate this room soon. But we need to be out of the building by 9:30. Very clear directions here. So, because I believe they locked the doors. And the other thing I want to mention is if you want to continue to be the conversation as part of a collective effort, we talked about sharing our experiences and best practices. You can send a series of messages for political candidates in the upcoming provincial election. So you can send them to Rose at Rose LM Tong, so Rose LM TONG at gmail.com. And I will leave you with that. Thank you very much and have a good evening.